All sessions will start and end on time.
Good morning, everyone. I welcome you all for the second day of ISHBT at Kochi. We start the day with ISHBT EHA plenary session, and the theme is bone marrow failures. And we'll start with a lecture by Dr. Carlo Defoe. Dr. Defoe is Director of Hematology Unit at Scientific Institute for Research and Healthcare, Genoa, Italy. He is involved with pediatric hematology with special focus on leukemias and bone marrow failure syndromes. His research activity is mainly centered towards the pathogenic mechanisms of marrow failures, on biochemical defects, and on clinical outcomes of rare diseases like aplastic anemia, Fanconi anemia, and severe congenital neutropenia. To his credit, he has got more than 120 publications as an author or a co-author. We invite Dr. Dufour to start his EHA plenary talk at ISHBT.
Good morning, everybody. Thank you very much, Professor Apte. Thank you, Christina. Thank you, Professor Gogoi, which I discovered we shared the training in past year in Hammersmith in London. And so it's a true pleasure for me to be here to attend such beautiful meeting, well, so nicely organized with such high scientific level. So my topic is a hot spot. It's related on the itinerary to make a decision on which treatment use in aplastic anemia in children. As a pediatric hematologist, is a topic I like so much. And so this is the table of contents of my talk. I will describe what the results and the outcome of the study, most important studies on immunosuppression in children are. Then I will go through the outcome of the match-unrelated donor transplant, still in kids. I will have a brief overview on alternative donor transplant, still in aplastic anemia, mainly in children. And then I will end up with some take-home message and with an algo, which is the one that has been supported by the EBMT new textbook, which is going to be published in early next year. So let's start with immunosuppression in kids. You will know that based on historical data that the overall survival of aplastic anemia in children is pretty good, is about 90%. And this is witnessed by studies conducted in the 90s, but also quite recently. And it means that with this type of immunosuppression, which is ATG plus cyclosporin A, you can achieve a reasonably good survival. The second question can arise, speaking of immunosuppression, is which ATG? We do have two fundamental studies. One is from Phil Scheinberg from Neil's group, NIH, which compared in a prospectively randomized way the use of horse ATG versus rabbit ATG. And as you can see here, both in terms of survival and of response, horse did significantly better than rabbit. This finding was confirmed by a study from our severe plastic anemia working party of EBMT, which confirmed that ATG from horse, that was a historically controlled study, does better as compared to rabbit in terms of survival, but also in terms of response. So based on these data, it looks like that the ATG is horse ATG. Then eltrombopag came. And again, NIH, Danielle Townsler is the first name of the paper of the group from Neil, added up to the classical immunosuppression, the eltrombopag. And in this series, which was made up of 92 patients, there were kind of 20% of patients who were below age 21. And this is a summary of the results. As you can see, overall response and complete response were quite good. One of the concerns, which is clonal evolution, showed that the rate is about 8%, all high grade, but still in line with those coming from historical controls. Neutrophils, red cells, platelet rescue was rather rapid, but particularly in that study, there was one cohort, the one in which eltrombopag was given quite soon from day one, which provided even better results, with overall survival at 6 months, 94%, and complete remission at 6 months of 58%. In Europe, we are running within the severe plastic anemia working party a prospective randomized controlled trials compare standard immunosuppression plus immunosuppression with the addition of eltrombopag. RACE is the name of the study, and Regis Pefot de la Tour from Saint Louis and Antonio Risitano from Naples are the PI of this study, which is quite close to finish the recruitment of the patients. You see that immunosuppression is a significantly good option in terms of survival, but if you look at quality of survival, of which event-free survival is an indicator, you know, when you investigate event-free survival, you consider death, relapse, non-response, clinical PNH, transplant after immunosuppression, and late malignancy as the events. Well, when you look at this qualitative indicator of survival, both in children and in adolescents, things look fairly different. So you see that the rate of event-free survival is quite lower, meaning that about 2/3 of patients, children and adolescents, do survive with a limited quality of life and severe limitations of daily life activity. And in addition to that, you know that immunosuppression is characterized by a risk of malignancy in terms of clonal evolution. I just, for simplicity, put the ranges of the percentage of clonal evolution in different studies, and you know that ranges between 8 to 21%. And is more frequent in those who do not respond, which is something that is likely to occur quite frequently, at least in the kids' population. But there's more than that. I mean, recently a Dutch group investigating adult population, not kids, in a prospective series showed that, the risk of myeloid malignancy is well represented, but that was already known. But what is new is that there is also a risk of increased non-myeloid malignancies, which rises up to 30%, up to 24% after 24 years. And again, the ratio between observed and expected tumors is far higher in the group of patients treated with immunosuppression as compared to what has been expected. Solid tumors are non-Hodgkin lymphoma, breast, colon, lung, and urothelium tumors. So the question of the long-term follow-up is particularly relevant in kids because, of course, they have a long expectation of life. And that's been addressed by this study, which is a continuation of a study that Sideroblastic Anemia Working Party of EBMT published in 2011. Andretti Kelly was the first name. This study was the comparison of immunosuppression, classical immunosuppression, plus minus GCSF. This is the continuation of the study, which is going to be submitted as a poster at the next ASH meeting, so it's a kind of novelty I'm going to show you. And I thank so much Andretti Kelly for giving me the permission of showing you this slide. So this slide says that if you have a long follow-up, the follow-up of this study was 11 years. If you project the survival at 15 years, you see that this is not so bad, and no difference between patients who received GCSF versus those who did not. But if you look at the event-free survival, again, the qualitative indicator, you see that the findings are far lower with the event-free survival in the ranges of 23, 24, depending whether the patient had or did not have GCSF. So importantly, young patients did not differently as compared to adults. So all that, what does it say to us? It says that, maybe this is not probably the best frontline option, particularly in the young population where the comorbidities are rather low and expectancy of survival is far longer than an adult or an elderly patient. And so that brings me to the second point of the talk, which is looking at the outcome of the match-unrelated donor transplant studies that are on the scenery. This is what everybody knows, that even in children, match-unrelated donor transplant does particularly well after the patient has failed frontline immunosuppression. This is a study from our group which shows that event-free survival, so qualitative indicator, is a very good option in patients who do fail frontline immunosuppression. What about the option of frontline? This has been investigated by the UK pediatric group along with EBMT in a control study with matched historical control studies, so it's not a prospective randomized study. Patients were conditioning with FCC, which is fludarabine, cyclophosphamide, and Canpath, and cyclosporin A was the agent provided for preventing GVHD. You see that the overall survival with this is excellent as expected, but it's also very good with unrelated donor with no significant difference. But again, if you look at the event-free survival, quality of life, you see that, unrelated donor transplant does significantly better than immunosuppression. Just a note, GVHD, which is a serious problem in aplastic anemia because you don't need to fight any clonal activity, is somehow contained below 20%, which can be better, I admit. So back to the event-free survival means that there's a far better quality of life for patients who have MUD versus those who receive immunosuppression also in children. Other studies confirm this issue. This is a Chinese study in which the patients received all the ATG, mostly were MUD. GVHD was, again, still a bit of a problem because chronic is 30%, which is not that low, although most of the patients became free of immunosuppression in a reasonable time span. But you see that also in terms of survival and failure-free survival, frontline transplant did better than immunosuppression. We then compare in the UK study and EBMT study the MUD versus the matched sibling donor, which is the first-line treatment, no way in the case of the patients with aplastic anemia. And you see that, again, data were very similar with no significant difference and figures in the range of above 90%, which is really outstanding. Other studies did confirm that, and that this is a Danish study, if I'm not wrong, in which you see the patients were mostly match-unrelated donor transplant, and you see although the survival was slightly higher in related donor setting, there was not significantly higher as compared to related donor. And GVHD in this case was contained to the levels of the UK study. Again, this has been confirmed by a Chinese study, large prospective multicentric study with alternative donor, where the patients were treated with FCA, meaning fludarabine, cyclophosphamide, ATG instead of Campart, low-dose TBI or Busolvex, depending on the local decision. Again, outcome very good. Transplant-related mortality a little higher than 10%, which is in the standard. Event-free survival 81.4%, and GVHD in the range of that of the UK study. Finally, we compare the MUD versus the MUD post having failed immunosuppression, and both in terms of overall survival and event-free survival, we detected that MUD does significantly better than MUD after having failed immunosuppression, thus pointing to the fact that there's no good reason in children for waiting immunosuppression failure for putting in place a good option, which is MUD after immunosuppression that works very well, as I've shown you before. Still on this line, the Japanese colleague, after having analyzed the outcome of 6 prospective studies, set up their own algo, which of course states on the top of the line the matched sibling donor transplant whenever it's available. But if you don't, the Japanese colleague decided that the patient, if does not have a family donor, has to undergo match-unrelated donor transplant or even one antigen mismatched, provided the patient has short telomere, which is a high risk for clonal evolution, and no PNH clone, which is a negative predictor of response. So so a brief overview regarding the haplo. Haplo is very popular. We attended a session Thursday morning in which data was really impressive. This is the classical study from the Baltimore group, including some kids in a cohort of 16 refractory patients. We were treated with unmanipulated bone marrow plus cyclophosphamide post-transplant, and the results were pretty good with all patients alive, low GVHD, low viral reactivation, no clonal diseases. This is another Chinese study. China is a country where a lot of haplo bone marrow transplants are performed, is on kids, unmanipulated bone marrow plus peripheral blood, GCSF primed. Some patients were upfront, some patients were as a salvage treatment. Overall survival and event-free survival below 80%, above 80%, I'm sorry, but chronic GVHD is still a problem above 30. The author states that there is no difference in the outcome between salvage treatment and frontline treatment. Our group explored recently the issue of haplo in Europe. Pedro Prata from our working party and Regis Fuderatur as a PI investigated the haplo option in Europe in the EBMT. There's going to be an oral and next ASH, and I can anticipate that results are not the same line as the Chinese, and that poses the need for prospective trials comparing the different transplant options. CORD is another alternative source. Again, the group of St. Louis is very active in this field, recently published in Blood. Regis is the first name. 26 refractory patients who didn't have a matching-related donor. The median age was still within the pediatric range, and the outcome was excellent with good survival, very good survival, but you see here with acute and chronic GVHD rate quite high because, I mean, it's over the range of 30 and with 45.8% with the acute, which is something really to take in account. So what? Coming back to MUD now. Data I have shown you indicate that it provides a better outcome than immunosuppression. They work the same as matched sibling donor, better than rescue and match the transplant. And this has been confirmed now in many different studies. And does this mean that we have to offer straightforward match unrelated donor transplant to have any children who shows up with a diagnosis, newly diagnosis of aplastic anemia? Not sure, really. There are some things that have been thoroughly evaluated. First, issue related to the donor. You well know that HLA match unrelated donor is not available for everybody because of the composition of the registry. And you see that Caucasians have higher chances of finding a donor in the range of 75%. These chances is lower for Afro-American citizens, or for South and Central American, with other ethnicities having intermediate likelihood. Then there are other donor issues related to the age of the donor, the gender, the pregnancies. We've heard on Thursday morning on how important is the age of the donor and how better the results are with younger haplo donor as compared to older haplo donors. The social cell is again important. Recipient is another issue. Patients with high aggressive infection are in serious need of quick treatment, or the same as those with high-risk cytogenetic clone. And an important issue is that data derived from the study I have shown you, unfortunately, are not all top level of evidence. Just to make it a little bit more clear, this is the pyramid of the level of evidence. You see that on top you have filtered information, on top of which there's meta-analysis. Then if you cut to filter information, you have on top prospective randomized trial, which is the highest level of non-filtered information. But then you have cohort studies or control studies, which is the level of the studies I have shown you so far. So, you know, it's difficult to run prospective randomized controlled trial in aplastic anemia, which is a very rare disease with an occurrence of 1-2 cases in a million. But there is an ongoing prospective randomized trial running in the US, and Michael Pulsifer from Los Angeles is the PI, and it compares the feasibility of, assess the feasibility of comparing immunosuppression frontline versus match-unrelated donor transplant in children with newly diagnosed severe aplastic anemia. So we're eagerly waiting for the outcome of this study, but for the time being, in real life, we have to rely with level of evidence study, which is lower than that. And so back to the final part of my, just reaching the final part of my talk, what, in my view, the amount of data I have shown you do say. You say that, I mean, match-related donor transplant is a reasonable frontline option in young patients below the age of 18 if the transplant is feasible, not the donor found. The transplant feasible within 2-3 months since diagnosis is an optimal option after failure of immunosuppression. As for immunosuppression, I think that is a first-line option in case you don't find a donor or if the MUD-related donor transplant becomes delayed after the time span of 2-3 months. And haplo is not very well established so far. I know it's very widely used in some countries. China is one, India is another one, because the donor is easily available and the costs are far lower. But based on the data we have, it looks by now, a good rescue option for refractory patients without matched sibling or match-unrelated donor. With GVHD is still a problem. You've seen data ranges in the range of the 30. And there's a need again, as in from this is the outcome of the EBMT study, for prospective control studies for frontline use in younger. And this is what is going on in Baltimore, where there's a frontline comparison between MUD and partially matched and haplo in new diagnosis, severe aplastic anemia children, and which is PI'd by the group of Baltimore. So all that finishes in a kind of algo. This is the algo that's going to be submitted. It's going to be shown in the textbook of the EBMT, which is submitted and ready to be printed out. You see this part of the graph, which is that related to person in the young part of the life. if patients below age 40 have a matched sibling donor, no way, frontline treatment, this is the option you have to go straight forward for. But if you think that the transplant is feasible, again, not donor available, transplant is feasible, is a fairly different story. And if you have a good match unrelated donor, 10 out of 10, 8 of 8, or 12 out of 12, and the patient is younger than 20 years, then you can go for unrelated bone marrow transplant, leaving the immunosuppression for those patients who are not able to find a donor. Last slide is my thanks slide. I would like to deeply thank friends and colleagues in the BMT Working Party, Regis Befort de la Tour, Antonio Risitano, all the staff of the BMT, and some special colleague from NIH, Neil Young, who is a close friend of mine, and the Brazilian colleagues like Phil Scheinberg, Rodrigo Calado, Danielle Townsley, formerly working with Neil at NIH, Professor Bijou George, who was like here in a meeting we had recently in Bethesda, and of course the BMT centers and the patients along with their own families. Thank you.
Thank you, Dr. Defoe. Thank you, Dr. Defoe, for an excellent presentation. Can we have a few questions from the audience? If there are no questions, can I have the question? Looking at the data for haplo, because in India the situation is different. Many times we are not able to offer two therapies, especially to children. And our own data, when we had looked into our own data with immunosuppressive therapy, is not so good in the ranges of 85–90%. So in that situation, some of us think that haplo may be a reasonable option, especially for pediatric age group. In long run, your data also on haplo has shown that it is quite reasonable to do if MUD or MSD is not available.
Yeah, this is an important issue, and I think that this question was not unexpected to a certain extent. So my statement was based on the fact that, I rely on what is evidence-based study in Europe, but I understand that in other countries may be different. I understand that sometimes haplo can be also first-line treatment in case you're not confident that immunosuppression will be working, and in case you don't think that this donor is going to be found. I was discussing yesterday with Professor Seiji Kojima, who is in the audience. They have excellent results with haplo, with post-cyclophosphamide. Other centers will have. I think that it can be an option. Of course, it goes slower. You have the donor right there. Studies still say that GVHD is a problem in the larger study. I think that we will probably learn more once the data from the prospective randomized study will be out.
No more comments, no more questions. I think we'll go to the next presentation.
Thank you, Carlo. The next speaker is Antonio Almeida, who's a consultant hematologist at the Portuguese Oncology Institute in Lisbon, Portugal. Antonio Almeida's interests include myelodysplastic and myeloproliferative syndromes, focusing on the epigenetic regulation and transcription regulation. He has written book chapters and is the author of a range of articles published in journals, including New England Journal of Medicine and Nature Medicine and Blood. Antonio is also chair of the curriculum committee at the European Hematology Association and has been a major person in the exam which our young hematologists all over the world can take. Thank you, Antonio.
Thank you very much, Christine. I'd very much like to thank the Indian Society of Hematology and Blood Transfusion and the European Hematology Association for the honor they've given me in being here today. And just as a small publicity for what Christine Chaumienne has just said, the European exam is open to all. At the moment, we're holding it during the EHA Congress, but if the Indian Society wants to have a site here, we are open to proposals. So let's talk a little bit about MDS. I've opted to have a very clinical talk to really try to bring home the issues that we have with patients with high-risk MDS that may need hypomethylating agents. These are my disclosures. And to make this very practical, I've chosen to work through some clinical cases with you to try and bring home the issues that we have every day. So this was a woman from my clinic. She was 74 at presentation. She presented with tiredness and with a skin rash. She also had occasional swollen joints. She had no significant past medical history. And her full blood count revealed what we normally expect in MDS. She had an anemia, a thrombocytopenia, and pretty much all the screening tests were normal. These are her legs. Just to situate you anatomically, this is her knee, this is the front of the knee, this is the back of the knee, and she had this skin rash, which on biopsy was shown to have a neutrophilic infiltrate compatible with Sweet syndrome. And this is her blood film, which is clearly a dichromic blood film with some hyperchromic and some normally hemoglobinized cells. Her bone marrow showed perinuclear vacuolization in the erythroblasts, and it came as no surprise when we found that she had ring sideroblasts with no excess of blasts. So we have a 74-year-old woman with a low blast count MDS with sideroblasts, and this brings to the question the big prognostic factors, because this is how we decide what we're going to do to our patients. And many prognostic factors have been identified, some in blood tests, some clinical, but perhaps the most important is cytogenetics. We know that MDS is a clonal disorder, which is characterized by cytopenias and with a tendency to progression to leukemia. And about 80% of patients have anemia, and 30% of patients will have thrombocytopenia or neutropenia. And the most important thing that we need to do in these patients is to be able to estimate their risk of progression so that we can treat them adequately. So low-risk patients we will want to treat with supportive therapy to reduce the impact of anemia, whereas in high-risk patients we want to halt the progression to leukemia. So if we go back to our young woman, she had a low serum EPO, she had low blast count, and she started erythropoietin. Probably like here in Portugal, cytogenetics takes a while to come back. So a month later, when she came back to clinic, she was found to have high-risk cytogenetics, which puts her in a higher risk group. But this was before the summer, and she had grandchildren for the summer holidays, and she said, oh, I don't want to start anything else soon. I'd prefer to wait, and unfortunately, she progressed. And I think this highlights how important and how powerful cytogenetics are as a prognostic factor in these patients. So this is our strategy in MDS at the moment. We have a diagnosis, we must stratify the risk, and then in low-risk patients, we have strategies to prevent the impact of anemia, and in high-risk patients, we try to prevent the progression to leukemia. And cytogenetics clearly has a very important role here. But more and more, we have recognized that there are other genetic factors, namely somatic mutations, that have an important impact. And if we look at the number of somatic mutations in a series of neoplasms, we see that AML, like MDS, are relatively monogenic. I don't mean monogenic, of course, but they have a low incidence of mutations when we compare them to skin tumors, etc. And most of the mutations occur in similar genes. And if we look at these publications from Munich and from Cambridge, and we see that most of the genes affected are all the same: TET2, SRSF2, ASXL1, etc. I won't name them all. And just before, like me, you get disappointed because you don't have access to mutational analysis on a routine basis, I would just like to show you this analysis from Germany. This is a very interesting analysis for the area of somatic mutations, where everybody is excited about somatic mutations. Torsten Haferlach looked at the prognostic factors in MDS. And if we look at the factors that have a high risk ratio, we see that anemia, thrombocytopenia, poor risk cytogenetics, all have a much higher impact in risk compared to any individual mutations. So don't be too disappointed if, like me, you don't have access to mutations, because simple analysis that we have access to day-to-day life really also have an important impact on prognosis. But let's go back to mutations, because even so, they give us a very good insight into what is happening in MDS. And if we look at the functional groups of the genes that are mutated, so we take the mutated genes, TET2, SRSF2, etc., and we split them by what they do, we see that we have a large proportion of patients who have splicing mutations, and this is divided more or less equally between low blast and high blast count patients. A high proportion of patients have DNA methylation mutations, and this now really favors higher risk patients. And we look down here and we see that most of the mutations will affect somehow chromatin structure. They affect chromatin modification and then transcription. Then, of course, we have mutations to do with DNA repair and transcription. So clearly, chromatin organization is central in the physiopathology, in the pathophysiology of MDS. And even when we look at the splicing mutations, because when I saw this data initially, I said, yes, this is very interesting, but splicing is pretty much a ubiquitous process. You know, all genes undergo splicing. So if we're splicing G6PD wrongly, then what difference does that make? But actually, the genes, the splicing mutations also mainly affect DNA repair, DNA cell cycle signaling, and chromatin structure. So we're going back to chromatin structure again and again. So when we look at chromatin structure, we need to see how chromatin is organized. It is highly organized in condensed DNA around histones. And the processes that regulate this are epigenetic processes. And methylation is a major process in regulating chromatin modification. And when we look at DNA methylation in MDS patients, it is aberrant in most patients, even those that do not have chromosomal lesions. So in orange bars, we have the patients with chromosomal lesions. And in the green bars, we see that all patients have a high rate of aberrant DNA methylation. And this aberrant DNA methylation increases with higher risk disease. So this is a normal person, low risk MDS, almost the same. But when we increase the blast count, we increase methylation a bit more. When we increase cytogenetic complexity, we increase methylation. And we look at cell lines, which are particularly aberrant, we have high DNA methylation. So it is associated with high-risk disease, but clearly also associated with cell immortality. So what are these epigenetic modifications? What is epigenetics about? Well, really, this is based on the addition or removal of small molecules, such as methyl group or acetyl groups, onto DNA or DNA-related proteins. And these small molecules enable the structure of DNA, of chromatin, to be changed, basically by changing the charges. So when we have DNA methylation, which is mediated by a series of enzymes, methylated DNA, simplistically, acts as a receptor for histone deacetylases. This deacetylates the histones and closes the conformation. So if we imagine DNA as a spindle, when it is open, transcription factors can add onto it, can attach, can replicate, can transcribe the gene. When the DNA conformation is closed, that gene is silenced. Of course, the process is far more complex, but simplistically, by acetylating or deacetylating histones, we can open or close DNA structure and silence or activate genes. And this is a normal physiological process, which in many tumors goes wrong. So how can we modify this? Why is this so attractive? Well, this is so attractive as a mechanism because unlike a mutation, which is there for good and is very difficult to remove or change, this can be manipulated pharmacologically. And the way that we have that most easily is most easily accessible to manipulate this are histone deacetylase inhibitors, are demethylating agents. Now, the main residue that is methylated is cytosine, and these are cytosine analogs. You will know them all well, cytarabine, azacitidine, decitabine. And they all can act not only as cytosine analogs, intercalating with DNA, introducing errors, and causing cell death, of course, but they can also act as methylase inhibitors. So they are cytotoxic. They do reduce blasts. Cells that are rapidly dividing will introduce any of these agents and will die. But cells that are not rapidly dividing will have an effect of demethylating DNA progressively, and therefore they will restore normal expression of genes. Cytarabine is mainly a cytotoxic. We've all used it again and again in acute leukemia, and it has very little demethylating activity. But decitabine and azacitidine are DNA hypermethylators, and both in cell lines and in vivo, we have evidence that they hypermethylate DNA. So who are candidates for these therapies? Who really works? I think we now have a very strong pathophysiological basis that DNA methylation is an important process in MDS, and that it could be a targetable process. So let's look at a typical case. This was a relatively young man who had quite a few comorbidities. He came to look for sunny climates in the south of Portugal, and unfortunately, after quite a long time of tiredness and shortness of breath and going to the cardiologist, eventually someone stuck a needle in his arm and found that he had anemia and neutropenia. He had a high blast count, normal cytogenetics, and if we work out his risk, this sort of patient at 62 with just supportive therapy has a high-risk disease. His expected time of progression is under 3 months, and his expected lifespan is about 5 months. I just say this because I think it's very important for us to put into perspective how aggressive this disease is. Often it seems a much more indolent disease than acute leukemia, but actually these numbers show that we do need to act quite quickly. So he became transfusion dependent, started azacitidine, and this had quite a quick action. 4 months later, he was transfusion independent with a partial response, which lasted for 10 months. He was not a transplant candidate because of his heart disease, and he was not a chemotherapy candidate because of his heart disease. So why do we use azacitidine? Well, I'm sure you've all seen the data from this trial. This was a trial published in 2009, in which patients with high-risk MDS were identified, chosen for the trial. At this point, the investigator decided whether the patient was candidate for supportive therapy, low-dose RC, or intensive chemotherapy. And the patient was then randomized to receive one of these 3 treatments or azacitidine. And to cut a long story short, patients who received azacitidine had a significant longer survival than those who were treated with conventional therapies, including intensive chemotherapy here. The main reason why patients with azacitidine had a longer survival, you can see here, is that they had a longer time to leukemia. So clearly this is not curative, but it has dramatically improved survival of these patients. And this is true for all comparisons. Of course, if it's just supportive care, you would imagine, stands to reason that having an active therapy is better than supportive care. But also, this is not just cytotoxicity, because cytarabine is cytotoxic, and still the survival is worse than with azacitidine. And despite, because of numbers not being statistically significant, even when compared to intensive chemo in this group, there is a higher survival with azacitidine. Another interesting fact is that this survival seems to be independent of the response that is achieved, as long as some response is achieved. So we are sort of formatted throughout our hematology training that the main objective in these diseases is to achieve complete remission. And of course, we all want to achieve complete remission for our patients. But if we look at this data, this is the survival curve of patients who were treated with conventional therapies. These are the ones who progressed with azacitidine. But whether they achieved complete remission, partial remission, or even only hematological improvement, improvement in platelet count or improvement in hemoglobin, the survival improvement advantage was still there compared to conventional treatments. And even if they had stable disease, i.e. no improvement at all, but no progression, they still had a survival advantage compared to conventional therapies. And this is very interesting. This clearly means that hypermethylating patients with MDS has a stabilizing factor on the whole disease process and does not allow it to degenerate into high-risk disease. Of course, this was a clinical trial, but like many, we have replicated similar data, 19-month survival in a cohort of patients with high-risk MDS. And this data has been shown again and again. Not all real-life data is the same as trials, but we have this experience in many fields, but the survival advantage is still there. What about other hypermethylating agents? Let's look at decitabine. This is an EORTC trial in which decitabine was administered every 6 weeks. It had similar response rates to azacitidine, about 34%. Quality of life was improved, but sadly, there was no survival advantage between decitabine and best supportive care. This is really very disappointing for this agent because obviously the more armamentarium we have, the better. There has been a lot of discussion regarding the doses of decitabine, and a lot of studies have been done with alternate doses of decitabine. I will not go into them in detail in the interest of time, but the fact is that none of them have been shown to have a huge advantage compared to other therapies. Now, I've shown you a patient who has normal cytogenetics, but poor risk cytogenetics is a major problem in MDS. About a third of patients have poor risk cytogenetics, and as I showed you in the first case, poor risk cytogenetics is particularly important in prognosis. And not only is it important in prognosis, when patients with MDS with poor risk cytogenetics are treated with intensive chemotherapy, their median survival is always less than 6 months. So the prognosis is poor, and the treatment options, the conventional treatment options that we use, are even poorer. But when we look at the azacitidine trial, we see that in the poor risk cytogenetics, this is where we had greatest advantage. Of course, poor risk cytogenetics still do worse than patients with normal cytogenetics or with good risk, but even so, their advantage compared to conventional therapy, 17 versus 6 months, is very marked. Most of our patients with MDS are elderly, and this reaches a big problem because this is the peak of age of diagnosis, over 75. And these patients have many comorbidities, have other difficulties in coming to hospital, in having care, needing care at home. And this really presents a big problem. But at the same time, before anybody says, oh, well, if they're very elderly, it's not worth treating them, we need to see that the life expectancy, and this is data from WHO in 2016, this is online data, in the WHO repository, we can see that if a patient reaches 85 in India, they really should be living another 5 years. So I now have a patient who's 85 and has high-risk MDS, which gives them a life expectancy of 6 months. If they did not have MDS, perhaps they would have a life expectancy of 4 or 5 years. So clearly, treating them does give them an advantage which is not beyond the natural course of life here. Do elderly patients do well? Well, they clearly do. Here we have a subgroup of elderly patients over 75 treated with azacitidine, and they have a survival advantage compared to those treated with conventional treatments. Now, I think we've seen a lot of data that azacitidine and hypermethylating in these patients is clearly advantageous and has an advantage in all risk groups, whether they are high blast count, poor risk cytogenetics, elderly patients. But we still are tackling the problem of having to have lifelong therapy, or at least until progression. And it is very important for us to try and understand why. And this very interesting study presented in ASH last year by the French group shows that azacitidine targets not the stem cell, but the granulocyte progenitors. And we can reduce the clone size. So in green are the malignant clones. This is when the patient progressed, increase in this red clone. And azacitidine is able to control this leukemic clone here, but then the malignant clone is still present. So as we progress throughout the disease, azacitidine is only able to control the median progenitors and is not able to control the stem cell that harbors the initial disease. And that is why it's not curable, and that is why we need to continue it until progression. The primary clone is unaffected. And not only is that a good reason to continue until progression, but the fact that the patients improve their response with time is very important. And for disease in where we're used to giving chemotherapy, like an acute leukemia, and then we do a bone marrow after a month and expect to see remission, this is particularly nerve-wracking. With hypermethylating agents, we get some response after 2 cycles, so this is 2 months later, but most patients only have a response after 6 cycles. And this is something I always tell my patients. You know, this is a treatment, but we do not expect to see anything before 4 to 6 months. So you will continue to need transfusions, you will continue basically as you are, and probably a little bit worse for a while until we see a response. And it is interesting that even after 6 months, we continue to get responses. So it is important not to lose heart and to carry on. In addition, it is also important to recognize that the best response is not the one that we achieve initially. Patients continue to improve their response with subsequent cycles in many cases. So only 50% of the patients have their best response after 4 cycles. If we continue to administer, we can get improved responses up to 12 cycles. How long should we continue this? Well, I've shown you the data that this does not control the primary clone, that it only controls secondary clones, and that the responses are delayed. So we really need to wait, unless there is obvious progression, for at least 6 cycles. So if a patient is stable in the first 6 cycles, I really try hard not to stop and not to delay. But this is not curative, so we do need to continue until toxicity of progression. And here brings the important point of toxicity. Azacitidine and decitabine have pretty much similar toxicities. They are hypermethylating agents, but they're also cytotoxics. So their main toxicity is hematological. It is important to recognize this because hematological toxicity does seem to aggravate the disease, and we need to support patients throughout this. There is also a large degree of gastrointestinal toxicity, partly because of the antiemetics we need to give, but also partly because of the drug itself. And no patient leaves my clinic without a prescription for lactulose because constipation is probably the biggest problem. And I don't know about India, but in Portugal, especially elderly people are obsessed with their bowels. You know, they can be falling apart, but if they don't go, that is the tragedy. So really, being proactive about constipation is very important. I know it sounds funny, but it really is. Finally, we have injection site reactions. Azacitidine is administered subcutaneously. It's very important to perfect injection techniques, so there's subcutaneous and not intradermal, because that is when the reactions are. And also, nobody leaves my clinic without a prescription for a steroid cream to apply in the injection sites, because this helps hugely. It's also important to note that most of these reactions last about 2 weeks. So we just need to brave it. But I think the more we know about adverse reactions, this is like any chronic medication, the better we can manage them and the better we can keep our patients on chronic treatment. And I'll just finish, like Professor Dufour, with an algorithm. This is from the ELN guidelines, and we can see that in high-risk patients, hypermethylating agents are there for almost all patient groups. And I'll just highlight that having a hypermethylating agent does not preclude a patient from transplant. And very often we have patients who have MDS, who are very unwell, who would never be considered for transplant because they're elderly and unwell. And they go into remission, they improve dramatically, and then they are able to go to a transplant and donors are identified. So don't feel that by choosing a hypermethylating agent as a first treatment option, we have to preclude transplant at a later stage. And this really summarizes what my day-to-day practice is in MDS. We use this in first line in all non-transplant candidates, which really are almost all MDS patients. But even transplant candidates, those who have high-risk cytogenetics, I much prefer using hypermethylating agent and then transplanting. We start at diagnosis because this disease is aggressive and there's very little time to wait, and then we continue until toxicity and progression. And I'll just finish with this slide because this really represents the path that we have to do. I think up to now, we've had a lot of experience with azacitidine, with decitabine. We have a lot of experience with single agents. But I think we really need to start braving the oceans because a lot needs to be done. You know, we look at these curves and we think, yes, we've achieved survival advantages, but they are 2 years rather than the 5 years that the WHO promises. So we need to start looking at more combinations, at different agents such as histone deacetylase inhibitors, and different modalities. They're all in clinical trials, phase 1, 2, still very early, and unfortunately, very few have shown a huge promise. But a little bit like the Portuguese explorers who ended here on the shores of Kochi, I think we need to be brave and try and sail uncharted territories. Thank you very much for your attention.
Thank you very much, Antonio. The discussion is open for questions now. Mamti, Shanda.
Thank you, Christine. Great talk. I have one or two questions. Number one, you start azacitidine, and 4 weeks later, you're supposed to start the next cycle.
Yes.
Your counts have crashed. Do you wait, or do you give the next cycle immediately?
Thank you for that question. I must say that I am very aggressive when I'm treating MDS. So there are lots of guidelines with lots of algorithms that you should wait until 50% of neutrophils are up, etc. Unless I have a patient who is clinically unwell, so unless they are admitted with an infection, unless they have a major hemorrhage, I do not wait in the first cycles. I treat the first 4 cycles like an induction phase, and I really carry on regardless. Obviously, if the patient is clearly unwell, then clinically unwell, then I stop. But I don't stop just because of the numbers. I carry on and I support them. And it's very interesting that many patients that start azacitidine, even before they have an improvement in their counts, they feel better because there's some reduction in the whole inflammatory process in MDS that improves their well-being.
Second question, after 6 cycles, you've achieved a reasonable response, cytopenia is improved. Do you continue 7 days a week, every 4 weeks, till progression, or do you reduce the dose of azacitidine?
Yes, that's another very important practical point. So, first of all, in terms of dosing, we have a limitation in Portugal because we don't have nurses at the weekend. I mean, of course we have nurses at the weekend, but we don't have a day hospital at the weekend. And in order to administer chemotherapy, it is a legal requirement that it is done in a hospital setting. And in order to get over this and not to have to bring patients as inpatients, which would be the only other option, we have opted for a shorter 5-day course. So our patients have the full dose. We do 500 milligrams per meter square full dose, but we divide it over 5 days, Monday to Friday. And that makes it easier for patients and for us. That's the first thing.
That continues indefinitely, till progression.
And then we use it until progression. After 6 cycles, I do assess the bone marrow to look for to do a blast count. And obviously, I look for hematological improvement. I sometimes then reduce doses, not after the 6th cycle, but after about 12 cycles. I do find that sometimes patients, especially the elderly patients, start getting late toxicity, and by reducing the dose to 100 milligrams a day for 5 days, when they are in response, I improve counts a little bit. So I do tweak the doses a little bit in real life.
Is there any data to show that if you stop after 6, which you achieve a response, and you continue, the median duration of disease control is longer?
That if you stop after 6 cycles, or if you can,
with the response,
yes.
are you continue? Is
Yes.
there a difference?
I mean, there's not a direct comparison. It has not been done. But there are quite a few papers by Maria Teresa Vozo and by ourselves that show that if you stop after 6 cycle, there is rapid progression with very difficult regaining of response when you restart. So it's not as if you can stop when you progress, you restart and you regain the response. You do not regain the response. The response rate is lower. And the survival of those patients is lower than the survival of patients in the trials and even in the cohort real-life studies that have continued until progression.
One last question. Is there any data on etanercept? One of my Googling patients comes and says, I'm high risk. Why don't you give me etanercept along with azacitidine?
Yes, I mean, there's very preliminary data on that. Unfortunately, the response rate is about 30%, and the survival is about 12 months in the small cohort. And that is the same for almost all, apart from guadicitabine, which now in EHA has shown some more promising results with over 14 to 15 months survival. But unfortunately, all of those, rigosertib, etanercept, etc., have not really, I mean, they're in theory very promising, but they haven't shown clinical advantage at the moment yet.
Thank you.
How will you treat the pediatric patient with high-risk cytogenetic, pediatric MDS?
High-risk cytogenetics, that is a particular problem because those patients have not only poor prognosis, but they also have very poor response to conventional therapies. So any patient with high-risk cytogenetics MDS, including young patients now in my practice, are started on hypomethylating agents, even if they are transplant candidates. Because what I've found again and again, we've looked at these cohorts in our clinic, is that these patients who have intensive chemotherapy first don't really go into remission. If they do, they relapse fast, and then they come out with all the toxicities of intensive chemotherapy. So high-risk cytogenetics is a particular group in which I think azacitidine is particularly useful. Patients with normal cytogenetics, and if they're young and fit, I would consider for intensive chemotherapy.
Thank you.
One last question.
Like some patients after 3rd or 4th cycle, they generally become stable in terms of like platelet counts becomes stabilized, they do not require. So like this is one of the markers. So are there any markers which you can say like after the person is not likely to respond, there's no point of continuing beyond 6 cycles? Or do we need to really add low dose RAC or something like that in those patients? Or do we have some thoughts on that?
Thank you. Yes, I mean, I think again that's very important because hopefully it'll become cheaper, but this is not a cheap treatment, and it would be very nice to identify the patients that respond better. The Spanish group have done a very interesting study in high-risk MDS and low blast count AML, showing that cytogenetics is still the main prognostic factor, and patients who have high-risk cytogenetics have a poorer response rate. But when patients are starting treatment, normally those that will do better are those who have a higher platelet count on the second cycle. That's been identified as an important prognostic factor. And those that have any sort of hematological improvement by the sixth cycle. So by international working group criteria, improvement platelets or whites or hemoglobin, they rarely improve their neutrophil count.
Antonio, thank you very much.
Thank you.
Well, we have just heard about the advances they are achieving in the European country in management of plastic anemia. But in India, the scenario is completely different. We have got about more than 1.2 billion populations, and we have got Adani, who can afford anything in the earth, and we have got people who cannot afford a meal per day. So it is really a challenge to manage aplastic anemia in India. We have Professor Manoranjan Mohapatra here, who will speak about the challenges we are facing in managing aplastic anemia in India. Manoranjan, he is the professor and HOD in the Division of Clinical Hematology, Department of Clinical Hematology at All India Institute of Medical Sciences, New Delhi. His areas of interest include bone marrow failure syndromes, leukemias, stem cell transplantations, immune thrombocytopenia, and thrombophilia. He has authored more than 350 research papers in various national and international journals, and is the editor of 6 reference textbooks in hematology, including D. Gross's Clinical Hematology. He is currently the Honorable Secretary of the Indian Society of Hematology and Blood Transfusions. Now may we invite Manoranjan to give his talk.
Thank you, Chairpersons, and very good morning to all of you. Coming back to aplastic again after the first talk, at the outset, thank the scientific secretary, scientific committee to assign me for this session. And they assigned me the topic, challenges in management of aplastic anemia in India. Before going to the challenges, I want to highlight the last 4 decades, there is a significant improvement in the treatment of aplastic anemia. Once severe aplastic anemia is one of the devastating or very severe disease, died within months. Now it's completely, at least in a great extent, you can cure a good number of patients in aplastic anemias. Same thing, there is a lot of improvement in India. In the last 7 to 8 years, we have good number of centers which can manage aplastic anemias, and when going for a transplant, and not even look for the alternate donor transplant in many centers. But the points is these are limited to big cities or metros. But the conditions, the aplastic anemia is common in our country in very low socioeconomic status. The foremost challenges, I will say in the next slides, is the tumor load, or sorry, patient load. Why? Because this is not so rare in India. We don't know what is the reason for that, but it's not so common. I will show our data, and then you can see and understand. And there is a lack of population-based epidemiological studies in India, so they can currently say what is the current prevalence or incidence of aplastic anemia in India. The major concern in real life is delay in diagnosis, because they usually refer months after to tertiary care centers because of the lack of facilities, especially in state government hospitals, to at least do a biopsy. What I have gathered from the lab colleagues, because more than 70% of the state medical colleges don't do a bone marrow biopsies, only aspirate. So you cannot diagnose aplastic anemia and that. So then only you can refer to tertiary centers. So that leads to a delayed referral. By the time they come to the tertiary centers, there is increased risk of infections, especially IFI, and early death before coming to that. That means they not received any treatment before that. So only few patients able to get standard care of care, that is either transplant or ATG or cyclosporine. So that we will discuss what percent of patients will get ATG, cyclosporine, or transplants. Cost of therapy, of course, is an issue in Indian setup, and it will stay, so it will not change. But I want to say around more than 80% of patients we see in our institute, it's very low equilibrium status, and good number of patients are below poverty line. But still, we manage to treat these patients because a lot of government funded projects are there, like Rashtriya Arogya Nidhis and other things, who can manage to do a transplant in this group of patients. I want to highlight some of the social issues. Even a group number of patients drop out. If there is a match, even if there is a match, they will not go for a transplant because maybe some social issues, like maybe sister is matched, but his in-laws not allowing, they are married. So I think we usually see around 20% dropout. If there is a match, they will not come for the transplant. So these are the issues you see in real world, how to manage these group patients. Of course, I put a last column, the lack of disease-specific support group. It's not an uncommon disease. Like you have seen, like thalassemia support group, hemophilia support group, they can push government to use funds for the disease, which is lacking in setting. I think in country like India, we should build up this. So these are the issues I'll highlight in the next few minutes. As I already said, there is no precise incidence or not known, but what we know is that 20 to 40% of pancytopenias in the tertiary college usually as aplastic anemias, and the annual incidence in one report shows around 7 cases per million per year. And it is much, much higher at Western populations. View data saying at 4 to 6 times higher. I'd say it may be more than that. Why this is common in Indian setup? Because possible thinking is high, maybe high. Many are low socio-status farmers, so maybe high exposure to the pesticides, chemicals, or toxins, or maybe easy access to the drugs, like open access to open-counter drugs they're using frequently, maybe infections like hepatitis, or these are the issues for that. So why, what basis? Because if you see, these are the data from mostly the lab, this is the biopsy reports, and they say it's allowed the aplastic anemia, one of the common patients present with aplastic anemia, one of the concepts present with the pancytopenia to their institutes. Coming to our load in this, you see, we cannot say it's a rare disease, okay, in Indian setup. If you see this tumor load, this is the year-wise new patients you see annually. As I had 400 patients in 2060, that means each month we are at 30 to 40 new patients come to the clinics. So this is a tremendous load. And if you see, we're not seeing only transplant, only aplastic anemias. This is only 10 to 15% of our hematology OPD load. So that's the major challenge we see in nursing. And if you see this year's, again, already by September, we have 340 patients in the new patients admitted to the business. So this is the real challenge to us. And for that, we have to make a clinic separately for aplastic anemias once a week. We issue around 1,500, 200 patients of CML, aplastic patients every day. So this is the major challenge we see face. Why? Because there is lack of centers treating aplastic and government setup, because these are 90% of patients are low economic status. And if you see, almost 20 states they referred to All India Institute of Medical Sciences of the major bulk of patients from Uttar Pradesh, Bihar, and Delhi and Haryana, and even from few patients from Nepal and other countries. So this load you can prevent if you have a lot of, even there is government is trying to have it like AIMS, like institute in many states, but still they are not managing aplastic anemia now. So that's the reason the load is gradually increasing day by day. It's more common, as you know, it's mostly in younger populations, bulk of the patients in second and third decades. There is always another bulk in the older age group, but we don't see in India setup the older patients referred to us as aplastic in elderly populations. But it can happen any age. You can see in patients as low as 2 years to approach 90 years of our patients, and bulk of patients are male patients. If you see why this is common, there is 2 articles you have, I can say about in India setup. One is from KGMC, is 25% of childhood aplastic anemias. But they've also looked for the organ chlorine levels in aplastic anemias. So it's around 7 cases per million. And they also looked the blood levels of organoids higher in aplastic patients, but didn't support any associations between their exposures and risk of childhood aplastic anemias. Similarly, one study from PGI also showed, this is a case control study of 100 patients with 200 controls of other diseases. They also observed the low socioeconomic status and younger age are the two important factors responsible, and the multivariate analysis showing these are for the aplastic developments. This mainly because of these patients, these are government issues, they usually compare low socioeconomic status. Similar experience in our setup was also done a few years back as a DM thesis with case control study with the two controls. And what we have observed, the history of drug intake is almost seen in 20-25% of patients, and chemicals around almost 30% of exposures. But none of this in multivariate analysis is reassociated, but the univariate analysis say low socioeconomic status, residents from the rural areas, occupational exposures, and household exposure to wood, smoke. These are all univariate analysis showed the risk factors for the aplastic mania, but none of them as on multivariate analysis. So we conclude maybe actual relative on risk estimation we need to have multicentric population-based studies required in India. As you know, these common are idiopathic, but secondary causes are not known. But what we observed in another group, the bulk of patients are severe and very severe patients because of the tertiary nature of the institute. But history of jaundice in around 5% of patients, some patients pregnancy-induced aplastic anemias, and the family history of aplastic anemia, 7 patients, and a cluster of patients from some villages, Bihar and UP. So these two group of patients we should investigate further, especially the geography-specific etiological factors, maybe, because these are all not inherited bone marrow failure syndromes we have investigated, and most of the patients are more than 40 years. So, but if you see the inherited bone marrow failure syndrome, which is almost around 5 to 6% of all cohorts, but around 12% of patients if you analyze in the childhood age less than 20 years of age. Coming to the diagnosis, this point I've already highlighted. As you know, the bone marrow is very essential for the biopsy diagnosis of aplastic anemia, not only for diagnosis, but also to exclude other conditions like hypoplastic MDS AML, hairy cell, maybe tuberculosis. And what the challenge is, if 80% of patients referred without a bone biopsy report or bone biopsies in these patients because of the lack of facility in state levels hospitals. And the no bone biopsy facilities, almost I've seen that part already. So it is essential to encourage bone biopsy and facilities in state medical colleges, and also not only doing the facility bone biopsy, also how to interpret these data. That's also you need to do workshops and train them so that they, at least they refer to the tertiary centers with a biopsy and diagnosis of the head, so that they delayed in diagnosis. Second major concerns about the presentations. Almost all patients present with anemia and thrombocytopenia, so in 70% of patients. But I'm worried about these infections. Why? Because more than 50% of patients with fever, but the documented infections we have seen almost around half of these patients with a severe fungal and bacterial infection at the before diagnosis. That means they are presented with a suspected aplastic anemia without a bone marrow report. And the duration symptoms of presentations almost 2 to 8 months with a median time of almost 4.5 months. So by the time they comes to us, there are many patients that can be salvaged before if you can refer them early. And again, they should know, at least before referring, they should know how to treat the febrile neutropenia beforehand. This is the major challenge. Third options, again, these are the bleeding manifestations, presentations. What we see, these can be prevented. Patient is present with IC bleed and everything beforehand, okay? So this is not referred early. So once you know this, why I'm just putting this is an old publication of 2011, but once time, if you see the decades, last 3-4 decades, there is significant improvement in the supportive care, in the blood component support, also polishing of the immunosuppressive therapies. So if you see this 147%, those are not responding to the immunosuppressive therapy over the decades. These group of patients also infection-related mortality also reduced, frequency of infective fungal infections are reduced, and also overall 5-year survival in non-responder was also significantly reduced over time. That's because of improved supportive care, blood bank facility, antimicrobials, and iron chelation facility. And most of these are there in India because it's most of all antifungals are available in India. And in multivariate analysis, if you see the younger the age, severe aplastic anemias, very severe aplastic anemia, absence of invasive fungal infections, and use of furunculars are more responsible. Those are responded, there is not much of difference over the years because responding patients to immunosuppressive are good, but they are not responding. There is a significant difference over the time because of the improved supportive care in our patients. Coming to the treatment options in India, because as you know, these are the transplant or immunosuppressive therapies. Of course, I put some second line or maybe therapies like growth factors are not used most of the times because only there is infections alone, but androgens, eltrombopag is a new addition to the kit for the, especially maybe in the refractory settings or maybe in upfront nowadays. And lastly, the unrelated haplotransplant, all the options are available in India. This is clear when there is HLA match, young, maybe 40, maybe 50, if it's confident, then if a match is there, you can take for the transplant. As the age advances, there is a chance of GVHD and other complications will be high. Why do a bone marrow transplant? Because there's usually a survival of successful BMT over the immunosuppressants and the curative intent, and there is always a chance of late clonal evolutions in this group of patients. Although there is a chance of, they are all multi-transfused patients, there is always a graft rejections or GVHD that will be there, we'll discuss subsequently. But there is high mortality and morbidity in older patients when the multi-transfused patients, and most of our patients are multi-transfused patients. What about the immunosuppressives? As you know, the standard immunosuppressive is ATG and cyclosporin. Those are not eligible for transplant. You can use ATG and cyclosporin. But about the half of the patients responded to that. Late clonal evolution seen around 10 to 15% and relapse in another 35%. So then 50% of the responders within 10 years, they can come back as a relapse or change to other clonal evolution to MDS or AML patients. And what we should also understand before managing these patients, the recovery often less than the normal, but adequate. There may be transfusion independence, maybe prevent some spontaneous bleed without major bleeding, or maybe neutropenic infections also reduced significantly in this group of patients. That's why we know horse ATG is better than the rabbit ATGs, but coming to the ATG in our patients, what we have observed is around 360 patients over the last 10 years, patients which is much less of the load patient of aplastic we see normally. Before 2007, we have used less dose in our patients, maybe 15 to 20 milligram for 5 days, but although they showed response in around 50% of patients, but now subsequently we increased to 40 mg because of the majority of patients with more high dose, the chance of CR in this group of patients. If you see the median age is 27 years and the response criteria, but what we observed, there around 60% of the patients have responded to ATG cyclosporin as compared to other treatments, and which is also evaluated in different age groups, either younger or in different age groups on all the chest. Same thing if it is very severe and aplastic anemia. If you see severe aplastic anemia, very severe aplastic anemia, there is a different in. So this group of patients, they will not do well in their setup because they are all progressed to very severe. Then they can look for transplant in the group of patients if there is no response in the group of patients. But if you again delayed referral this group of patients, many patients come to us with a very severe aplastic anemias. So if you see the Indian experience, a lot of publications on ATG cyclosporins in this group of patients almost vary from 50 to 80% in some series, 80 to 87%, but most of the are uniform around 60% of response in ATG and cyclosporin group of patients. Hey, what about the eltrombopag? As you know, this is the new drug which used previously as in ITPs and subsequently used in refractory to immunosuppressive therapy in aplastic anemias, and also a few data on first-line immunosuppressive therapies. Before going to the immunosuppressive therapy, eltrombopag, so one and two should understand this immunosuppressive therapy, eltrombopag along with immunosuppressive therapy, the dose used is very high as compared to ITP. So response is usually seen around 100 to 150 milligram, 25 to 50 milligrams. So the cost of therapy is significantly high, maybe another ATG dose, so that will be soon. So that's we have already discussed yesterday, day of yesterday's, but this also again see, this is the sign where you can use the fast trials. On that basis, you see the very significant improvement in the overall survival over 6 months on this group of patients. With the not response to immunosuppressive therapies, this also this shown by the first author, the first speakers, they actually unmatched in this group of patients related, showing a significant improvement. The last analysis of European registry showed this is as good as a matched sibling transplant in this group of patients. And also the recent data showing haploidentical transplant in those refractory aplastic anemia also showing a good response. So, and also for last 2-3 days we are also hearing the transplants in haplo patients in Indian few data is also available. So I'm very happy with that. But the problem we faced in transplant, even in aplastic anemia, is the duration of diagnosis to transplant is too long. And most of the patients they refer to us are heavily pre-transfused and usually not leukodepleted in irradiated products. Around 30% of the patients are severely infected with fungal infections. And almost all patients received immunosuppressive before transplant. So they are all bad prognosis, very bad case of patients of plastic anemia before taking for transplant. Second major challenge is finance. As you know, there is a universal state-funded healthcare system in India, but nowadays, of course, government trying to use some program to all of the patients, insurance policies. And the graft failure is almost a non-salvageable in Indian setup because patient can go for transplant whatever in the first go. Once relapse, it's difficult for in our Indian patients to go for another transplant in this group of patients. So early engraftment and prevention of the graft takes over priority over the chronic GVHD in our patients. So if you see the most of the centers, the peripheral graft is preferred in our India over the bone marrow graft and that's it. These are the data from the Indian Starter Registry. I thank Dr. Biju to give supply 2 slides to me. To the durations over the Indian stem on aplastic anemia till now, it's almost 758 in Indian, and peripheral blood is 631. That's also show that peripheral blood is more used as a graft in Indian setting because of the multiple transfused patients you usually see in our patients. These are the transplant centers. Used and different in aplastic anemias. These are the data again supplied by Dr. Biju to me. Okay, so the good part is centers are significantly improved over the years. But the real challenge here, what happened? This treatment options in aplastic anemia. If you see this load, the only standard of care we are giving almost 25 to 30% of patients. Almost 50% of patients received either cyclosporin and combined with menabol. So we have to do some things to push these patients at least receive the standard of care, which we are lacking. And a good number of patients not received treatment at all because they are all delayed referral with a bad state, they come to us. Even many can afford cyclosporin continuously. But I'm to highlight this, we have to use some policy or use support group who can use, many patients can be treated at least to the standard care of patients. These are the real challenge you will see. Even if you talk for the transplant, most of these cases require a financial grant and takes time, it takes time. So almost all patients received immunosuppressive therapy before coming to us. Few more slides for the transplant. There was around 109 transplants, patients with 111 allo transplant we did with one Fanconi's anemias. Most of them are young. Peripheral blood, again, 90% of patients. But I want to highlight pre-transplant infections is almost 40% of patients, and the pre-transplant number of transfusion almost more than 60 number of patients. These are all very bad group of patients. We usually use flu-cy plus or minus ATG. Those are multi-trans. We usually use ATG in those group of patients. And the median, this is the normal characteristic. But what I have to say, the infections, around pre-existing infections in our patients, almost 40% with documented fungal and aspergillosis before transplant. So they're all bad patients. That's the reason we usually use peripheral blood sources. And they worried about the GVHD, but you see around 30% of chronic GVHD in our patients, but it's not too bad the severe of chronic GVHD because they are all bad patients. They cannot salvage without doing a peripheral graft in this group of patients. These are the 4.5-year follow-up. The survival is around 76%, 83% of patients, and most of the cause of death, infections, few patients are graft rejections and bleeding in very early stage in this group of patients. I just made the 2 more slides to say, because cyclosporine, because the bulk of our patients on cyclosporine, why not to give androgenal C, which is better? So that's the reason we have completed study in few years back to look for, give half of the patients to cyclosporine and along with the danazole. What we have observed, the combined arm, there is a GI upsets and hepatotoxicity more in this group of patients, so there is a frequent interruption in this group of patients. And this blood transfusion requirement and use of antibiotic, antifungals is same in this group of patients. But if you see the overall survival, the trend may be more with combination arm, but there is not much of significance because of the few interruptions in this group of patients, So to summarize, in Indian setting, if it's algorithm, you will see this there for long, young patients, essentially MAT transplant, that's no doubt. But if it's no transplant, you can try ATG cyclosporines. Now, of course, plus or minus eltronumab is better. If you can, patient can afford, you can add eltronumab. We have not much of experience with this because many patients can afford this group of patients. Only one patient who have used this. So we have to see in India how the combination of in the first number will help in this group of patients. If there is no response for 4 to 6 months, why put 6 months? Because usually 4 months, 6 months, because our patients are usually, so we have some patients seeing more than after 6 months too. If there is response, you can continue cyclosporine and taper slowly. If there is no response, you can try eltronumab again with the TG cyclosporine, and if there is no, you can look for the transplant and other options in their setting. I just put here because a lot of data we just see by the first speaker now, the young patients better with the either unrelated transplant or alternative donor transplants. If I put it in Indian setting, you can see, you can use as a first line or not, or you can use immunosuppressive before looking for that. But as a part of clinical trial, we'll see our Indian data followed by you can recommend this group of patients. To summary, this is usually this is same, most of you have seen in the first slides. The precise incidence of aplastic is not known. We need to have epidemiological clinical data, population-based data, especially maybe you can have a small registry in multiple centers and combine and have a Indian registry so that I can encourage our data for patients. And the delayed diagnosis and referral, the major issues in our country, especially increased rate of infection and early death before treating this group of patients. And 25 to 30% of patients only get the standard care in our patients. This is the real life. And the cost of therapy, I've already said, it's good. It's even if the cost of therapy is an issue, but I think a lot of government programs is available, even company-sponsored program like All India sponsoring hemophilia, why not, thalassemia, why not aplastic anemia in this group of patients. And the early therapy definitely good if you use them properly in the patients. So in our setup, this transplant is almost 80%, ATG 60%, cyclosporine 40%, and we have to see what is the combinations for immunosuppressive and eltronumab in our Indian setup. Thank you very much.
Thank you, Professor Manoranjan, for nicely presenting the challenges we are facing in management of aplastic anemia in India. Now we're running out of time. We can have only one question. Yes. Okay. If there are no questions, I think we'll have to wind up the sessions.
Okay.
And myself, Christine, and Sasikrant would like to thank the organizers for giving us this opportunity to share this session. Thank you very much.
I thank the speakers and the chairs of the EHA ISHBT Symposium. The next session for this morning is the Malti Satya oration. The chairpersons for this session are Lieutenant General Velu Nair, former Director, General Medical Services Army, now the Group Head of Comprehensive Blood and Cancer Center and the past President of ISHBT, and Dr. Prantar Chakrabarti, Professor of Hematology, NRS Medical College, Kolkata. I now invite the chairpersons to conduct the session.
Good morning, ladies and gentlemen. On behalf of my co-chair and myself, we are indeed honored to be here to chair this prestigious oration, the Malti Sathe oration. A few words about Dr. Sathe. Dr. Malti Sadashiv Sathe is popularly known as Sathe Bhai amongst the colleagues and staff of the Institute of Immunohematology, which is now called the NIH. It's actually become a national institute, and she was one of the main pillars of this institute. Born in 1928 in Sholapur in Maharashtra, she obtained a BSc in Botany and Chemistry from the well-known Ferguson College, Pune, and completed a diploma in medical technology from BJ Medical College. In '57, she took up a job at the Union Memorial Hospital, Baltimore, in US, and completed her medical technology course of the American Society of Clinical Pathologists. She joined the Blood Group Reference Center in 1961 as a research fellow and obtained her MSc from Dr. Purandre and then her PhD from the famous Dr. Bhatia. She's well known in the circles of hematology, and largely she has worked in seroepidemiology and in the blood groups, especially in the weaker variants of A and B and the Bombay phenotype. She has mapped all the families of Bombay phenotype, and actually in the literature has reported the highest frequency of the Bombay phenotype, which is 1 in 4,000. She's also worked on the ABH antigens in various diseases and pregnancy and blood group specific transferases in Bombay and para-Bombay phenotypes. There is a well-known genetic atlas which has been published by the NIH, and this describes the different blood groups in the tribal and the non-tribal population. It's a lovely atlas with those of you who have not seen it, and it contains a large part of her work. She was single, and ultimately we lost this great researcher. She succumbed to ovarian carcinoma in 1999, and in her family she's survived by her brother, who's a statistician. They instituted this award. She was the life member of several scientific committees and also the past president of the Indian Society of Hematology and Transfusion Medicine. She retired as the assistant director in 1990 from then IIH. That's a brief thing on Dr. Malti Sathe, and I would actually ask my co-chair to introduce the speaker and the awardee this year, Dr. H.P. Pati.
Thank you, sir. It's a privilege for me to introduce my teacher, Dr. Haraprasad Pati, as the orator this year. He is the professor of hematology at Department of Hematology, All India Institute of Medical Sciences, New Delhi. His areas of interest in hematology include acute leukemia, MDS, hemostasis, functional platelet disorders, venous thrombosis, particularly splanchnic venous thrombosis, red cell enzymology, hematopoietic cell colony and culture, electron microscopy, immunohistochemistry, and flow cytometry. He was the first in India to start the EQUAS program in hematology way back in 1987, when quality assurance in labs was just a drawing room topic and not in mass application, as it is today. This work has now transformed itself into the All India Institute of Medical Sciences ISHBT EQUAS program with more than 1,500 participant labs. He is presently the editor-in-chief of the Journal of Indian Society of Hematology and Blood Transfusion. He has more than 200 research publications, which include more than 100 publications in international journals. He is the co-editor of 6 books on hematology and has contributed about 30 chapters. And those of you who do not know him well, I can tell you he also has a very good heart, and I still remember that we used to steal cookies from his room and then replenish them later, and he was aware of it. So I now request my co-chair, Dr. Velu Nair, to hand over the certificate to Professor Pati. So it's my privilege to invite Professor Pati to deliver the oration on aging hematopoietic stem cells and hematolymphopoiesis and its reversibility.
Thank you, Dr. Prantar and the chairperson's good introduction. I thank the society for selecting me for this year's a prestigious oration on whom honoring in the name of Dr. Malti Sate, a remarkable lady. Why I choose this topic of aging hematopoietic stem cells? When you talk of stem cells here, everybody presumes it is stem cell transplant. But there are a lot of basic research going on on stem cells, and even some works on also reversibility. So let's know particularly the basic hematologist of in India should be aware of the massive research also going on in this area. The biology of this aging process with increased life expectancy, many hematologists are showing a higher frequency in older age that we know. We know there is increased anemia in elderly. The myeloid diseases like AMDS, the myeloid leukemia, AML, they are increasing. And also simultaneously there is a basic thing is reduced the immunity called the immunosenescence, reduced ability to recovery from the immunity, like particularly after the stem cell transplants in older age, and reduced ability to tolerate the myelosuppressive drugs. And also stem cells from the young and old are also found to be, they are different. And there are many journals, these articles are published in many top journals like Nature, Science. Not only that, there is even one journal named called the Aging Cell. So aging stem cell is taken as an important area of research. Now start from the basics. Who maintains the normal steady state hematopoiesis? Who is producing the normal hematopoietic cell, the mature RBC, platelets, and the WBC or lymphocytes, what you see. The earlier dogma was that all hematopoietic lymphoid cells, starting from a common hematopoietic stem cell, who is differentiated to a long-term or the LT hematopoietic stem cell, then to a multipotent progenitor called the MPP, and then the producing the maturing cells. And this, so maintaining a normal steady state, there is a continuous division starting from the beginning, from the most primitive hematopoietic stem cell stage to the latent stage. And these works are based on mostly the culture-based studies and on irradiated mice, as you know, the splenic colonies and all that. But if to look into that, the transplant studies are unlikely to be physiological, as stem cells face the myeloablative stress and distorted the cytokine milieu related to that. Now there are more conclusively it is shown that the hematopoietic stem cell, the LT HSC or the short-term HSC, the multipotent progenitor cells, it is the long-lived multipotent progenitor cells are the abundant number and the main driver of the state hematopoiesis during mostly the adulthood. And the primitive hematopoietic stem cell and the long-term hematopoietic stem cell mostly remain dormant and the divide much rarer. And these are more nowadays based studies are on the barcoding techniques in which the long-term, the clonal behavior of stages of hematopoietic stem cells and the progenitor clones are done by inserting a random DNA sequence tag into the viral vector, and the tag is integrated into the genome of the stem cell and inherited by its progeny. So the individual daughter cells will inherit this, the barcoding will be there. So that will be more specific to look into which cell is actually dividing and producing cells. The normal bone marrow niche that consisting of the mesenchymal stem cells or the mesenchymal stromal cells called MSC and endothelial cells which produce many cytokines and extracellular matrix. The mesenchymal stem cells dividing into osteocytes, adipocytes, chondrocytes, fibroblasts, and also many specific perivascular cells and sympathetic nerve cells. The osteoblasts also expressing receptor for several neuropeptides, and the osteogenic cells or the osteoblasts are producing many cytokines, CSF, TPO, angiotensin, all that. Where we are aware of the two bone marrow needs are there, the microenvironment. One is the endosteal niche, and several studies are shown that the stem cells are localized near the bone surface. And because that provide a more hypoxic environment to maintain the hematopoietic stem cells in a quiescent stage. And the other one is the perivascular or the sinusoidal niche. It is the intertrabecular area around the vessels. And it is shown that the aged hematopoietic stem cells, there is impaired adhesion properties, and they are more skewed towards adipogenesis than osteogenesis. The endosteal niche, as you are saying, they are closer to the bony, the trabecular areas. And there are also many specific cells like the MSC, that the nestin positive mesenchymal stem cell. There are stem cells, and they are important, like particularly the aged hematopoietic stem cells are more present away from the endosteum, and they are more closer to sinusoids. So they are more in the perisinusoidal niche than in the endosteal niche. So there is a migration is happening. The good amount of the research in mice and also in human on the aging has shown that in aging process, that what is observed that there is increased number of hematopoietic stem cells, but the proliferative capacity is reduced. There is increased hematopoietic stem cell mobilization from the bone marrow to the peripheral blood, but there is a reduced homing efficiency. It's not going back and able to home so that's a problem there. And there is reduced proliferative response to the cytokines. The age-related clonal shift from the compartment that gives rise to another thing that is called increased myeloid bias at the expense of the lymphoid bias hematopoietic stem cells. The younger the population, the younger the person, younger the age of the being, they are in more, both of the stem cells are present, the myeloid stem cells as well as the lymphoid biased stem cells have the number of lymphoid biased cells much higher than the myeloid biased cells. As much as the age advances, this reverses, and the myeloid biased hematopoietic stem cells are increasing in number. So that is again a problem associated with the aging process. So what exactly the myeloid biased hematopoietic stem cells? This is a study in human beings in more than 70-year age of the marrow hematopoietic stem cells. They have shown that is reduced in the common lymphoid progenitors and increased the megakaryocyte erythroid progenitors. So with aging, the age-associated hematopoietic stem cells show a upregulation of many myeloid genes, like RONX1, the HOXB6, and that causes a increased the myeloid bias is happening in older age. Not only that, about the lymphoid cells, as I said, that there is they exchange reduced in the number of the lymphoid lineage progenitors. So that is also already demonstrated that the reduced level of T and B lymphoid lineage progenitors, and they also express low level of interleukin-7 receptor on T cells and respond less to the interleukin-7. It's a key regulator, IL-7 is of the human and the mice T lymphopoiesis. The immunosenescence is a very important finding associated with aging, and this is some researchers consider immunosenescence an important aspect in aging process. Well, as you understand that in aging process, we observe that there is increased susceptibility to infection, higher autoimmunity, more anemia, the lower efficacy to vaccination. These are already observed. And what we specifically observed that impaired V and T lymphopoiesis reduced the naive B cell population in the peripheral blood, reduced naive T cell population, though the memory B cell or memory T cells are higher number. The same thing also happens with the NK cells, there is reduced cytotoxicity function and cytokine secretion. This is another study in human, the age-associated T and NK cell precursor changes, the normal human peripheral blood circulating hematopoietic stem cells in the aging, so the age-associated increased proportion and absolute number of NK cell progenitors and NK to T cell ratio increasing with age, and gradual reduction of the naive T cell population. So it means that with aging, the lymphoid differentiation potential of the peripheral blood progenitor cells, they are shifting from T cells to the NK cell. There is also change in the adhesion molecules in hematopoietic stem cells with aging. The adhesion molecules, as you understand, are very important for stem cell homing and the mobilization. Compared to the younger population, the aged people, they show the reduced level of the adhesion molecules like SDF1, the VCAM1, and increased level of things like P-selectin, the ICAM1, the PKAM1 expression, and also the NFKB response pathway. And most of them, as you have seen that the P-selectin, ICAM, they are all again are pro-inflammatory factors or considered stress factors. The aged hematopoietic stem cell, again, compared to the young, they are shown the impaired adhesion properties would reduce VCAM1, and therefore there is increase, so therefore they can explain the higher mobilization into the blood in response to chemotherapy and cytokines. The numbers increase, but the homing capacity decline. This has also been again studied in both in human as well as the mice study as well. The numbers, the circulating hematopoietic stem cell number increasing with age. In the mice also it is shown that they are with aging, young mice, they are less in number, but they are more active and producing more large number of clones. But with the aged mice, they are smaller clones with less self-renewal capacity. And homing pattern as a quantitation, people have shown that there is a twofold reduced the homing ability of the stem cells. A recent study published in Blood in 2018, this is this year only, that in the aged macaques, they are more, there will be more, the primates are there. So they are shown that with aging, that is impaired and delayed the long-term progenitors, which we consider as the most important to maintain the steady-state hematopoiesis, that is reduced number of the multipotent progenitors and reduced cycling of the long-term multipotent progenitors as well. Again, this study is all based on the barcoding techniques. So we summarize that what exactly happening in hematopoietic stem cells with aging. There is low repopulation potential, less homing, the myeloid lineage bias is there, there is an immunosenescence and impaired adhesion. Now to come to why or how these things is happening. The exact mechanism is not known. There are still a lot of work is already done. So I have, most of the works are really related to the intrinsic changes in the hematopoietic stem cells, and some work also done on the extrinsic. There could be also factors which could be again there is alteration and affecting the aging process. I will have labeled them under the six categories. They altered cell polarity, the mitochondrial DNA damage by reactive oxygen species, impaired autophagy. Epigenetic changes is another important area to the impaired DNA methylation, the histone acetylation. The another important area is the increased inflammation in aged hematopoietic stem cell. Again, this is considered is possibly maybe the central to all the process, the changes happening are related to higher inflammation. And the last one is, of course, the DNA damage and telomere shortening. The first one is cell polarity. And what is cell polarity? The cell polarity means it refers to the distribution pattern of the DNA, RNA, proteins within a cells. In aging hematopoietic stem cells, both studies in human as well as the murine studies, it is found that one gene, that is the CDC42 gene, that is the cell division cycle 42 gene, are overexpressing and related to the aging of the person. The higher the age, the higher the overexpression of this gene and producing the CDC42 protein, higher quantity of this protein. And the hematopoietic stem cells overexpressing the CDC42. So all the aging process, as we have seen, there is loss of repopulation potential, there is increased myeloid bias, there is altered cell polarity, and also again, the higher higher activity of the CDC42 again relates to mortality in the aging elderly people as well. This is studied in aging hematopoietic stem cells in the grandparents. This showed that two genes, including this gene of CDC42, they are strongly overexpression and they are strongly associated with increase the biological the age. And this CDC42 gene is also important in not only the cell polarity, but also cell-to-cell and cell extracellular matrix adhesion, and also role in longevity. Coming to the second one, the mitochondrial damage, oxidative damage by the reactive oxygen species. If we are talking of the quiescent hematopoietic stem cells, there is a low metabolic rate and low hypoxic nature of this niche where it is there, homed, and have reduced level of the ROS and low oxidative stress. But aging hematopoietic stem cells, there is reverse occurs. There is higher generation of the reactive oxygen species, causing the oxidative damage and affect the replication and the transcription of the mitochondrial DNA and the impaired the mitochondrial function. And the reduced mitochondrial function in turn again produce a higher amount of the reactive oxygen species, and it enhances the mitochondrial damage as well as mitochondrial mutation. So there, again the DNA damage and DNA of the mitochondria again has been observed with aging process. The mitochondria is very important because the somatic DNA the mutations increase with age has been shown, and the mitochondrial function also decline with age. And mitochondria is not only related to many aspects, there are many aspects including the inflammation, the cellular senescence, the stem cell functions, the mutations are also happening. With aging, many things are happening. And one is, I said about the inflammation. The more the mitochondrial damage, the higher the reactive oxygen species. The inflammatory steps are again activated, producing inflammatory cytokines, the tumor necrosis factor, the interferons, and different interleukins as well. Another third aspect is that autophagy. That impaired autophagy, again, another intracellular aspect, important thing. The autophagy is the non-pathway of degrading in damaged organelles the recycled amino acids by lysosomes, and critical to maintain the cellular hemostasis in normal and also the stress conditions. The autophagy in which the damaged component are really encircled and is taken care inside into a the autophagy is formed. It's called the autophagosome, and which then lies with attached with a lysosome which is present inside the cell, and then they are lysed in a contained manner. That is what the autophagy is. The hematopoietic stem cells, as every cell is, also require the autophagy to get rid of its waste products in the quiescent stage. And the aged hematopoietic stem cells, the autophagy again is impaired. So that has been shown with increased the reactive oxygen species. And one marker also of the senescent marker, the P16 Inc4A, that's again increases and is associated with loss of regenerative abilities, undergo senescence, and stem cell exhaustion. Again, there are some the genes are also again has been shown to have a regulator of the autophagy. The mTORC1, mTORC2, there are two important genes has been identified. The mTORC1 is a particularly important, is the mammalian target of rapamycin complex gene. It has many crucial functions. The one is, I said, the autophagy. It promotes the mRNA translation and protein synthesis, and functions as a serine and threonine protein kinase that regulates cell growth, cell motility, and cell survivals. And second, the activation of the mTORC1 is associated with higher inflammation. Inflammation is again, as I said, that is many aspects is important with the aging process. The another one is the area which we say associated with the aging is the DNA hypermethylation, the reduced histone acetylation, and they are hallmark in both aging as well as also in malignancy. The murine marrow hemolytic stem cells in aged has shown that there is aberration in the DNA methylation, histone methylation, histone acetylation. The aged hemolytic stem cells show significant degree of global DNA hypermethylation. And a lot of these mutations, which you are aware of the TET2 and DNMT31, these are the important mutations we have seen in MDS, AML, these CHIP also, and also occurring in the aging process. These mutations cause the loss of function, and that lead to DNA hypermethylation and aberrant hemopoietic stem cell function. The other genes like the somatic mutations like TET1 and TET3 DNA methylation proteins again cause increased aberrant DNA hypermethylation.
Dr. Pati, 5 minutes to go.
Yeah, sure. I'll finish that. So DNA, the methyl transferase DNMTs are important as a group for reduced activity in the aging as well. This has also been shown. But the restoration of the TET2 function is not, though it is reverses many things, but however it is shown the leukemic changes. So this is not a pathway one can use for the reversal of the aging mechanism. There are few, another one is that CYP3 is an important protein in the mitochondrial nucleus. Again, this is important in the global acetylation of the mitochondrial proteins. Again, that's again is affected, is down-regulated with the aging process. Inflammation, as I said, is important because there are many similarities are observed in hemopoietic stem cell inflammation and in the aging with that like the myeloid bias as observed in hemopoietic stem cell and increased reactive oxygen species produced. There is subclinical inflammation evidence is there in the serological studies, as well as another important pathway is the NFKB, the signal pathway is the important one and is important in inflammation and also role in apoptosis and is also activated in the aging process. I'll not go into the detail, but to say that NFKB pathway has role identified with arthritis, asthma, cancers, and inflammation. If you stay, recently it came in this paper that in family with sudden death and their depression again associated with inflammation. This pathway is quite important because the aged stem cell, you can see that they increased P-selectin and ICAM1, which are inflammatory the markers, are increased compared to the young stem cells. They are increased markers of that. The DNA damage is the higher quantity of the DNA damage already has been shown in the aged population. The telomere shortening also has been observed, but however, the telomere is not sufficiently shortened during lifetime of an hemopoietic stem cell, and alone, if sufficient, in aging process is not clear. So that's why I kept But the end, DNA is not an important mechanism. So it summarizes different mechanisms of cellular defects in aging process, starting from the mitochondrial damage, increased production of ROS, the DNA damage, telomere shortening, loss of cell polarity. So all of these factors are there. So the cell exchange mechanism are not much is known, but some conditions like neuropeptide deficient mice have significantly reduced number. So it is an area which is less explored. Last is about whether there can be reversible, is aging process can be reversible. There are two important genes which we came across, that is the CDC42 and the mTORC gene. So one is associated with the cell polarity, other one is the autophagy. So two studies works has already been done in the two areas. The CDC42 inhibitor, that is a casein, has been used. That casein inhibited the stem cells in mice has been shown to, the immune system has been rejuvenated, reconstituted T and B, the cell subset, restored the cell polarity. The aged casein-treated long-term hematopoietic stem cells transplant did not show any functional changes when compared to young, the long-term hematopoietic stem cells. The other is the rapamycin has been used as an inhibitor for the mTORC1. So the rapamycin has been used in transplants to prevent allograft rejection. It is also used in stents. The rapamycin eluting coronary artery stents also, this FDA approved long back. And this rapamycin treated hematopoietic stem cells in old mice has been shown that is enhance the stem cell in vitro degenerative capacity with increasing production of B lymphocytes and reduced the myeloid bias. The one area, the calorie restriction or the long fasting, again also has been shown to reverse the hematopoietic stem cells. The calorie restriction without the malnutrition, the delays aging, extends lifespan, and a 20 years long-term study has also shown that that is reduced age-related death, reduced incidence of diabetes, cancer, as also has been shown. How calorie restriction and long fasting they work, the strong signal pathway activation of the growth hormone, insulin, or insulin growth factors is a killer of stem cell and cause of aging, and the reduced the signaling pathway increases in lifespan. The calorie restriction has shown that there is the signaling pathway is reduced activation and reduced blood level of the insulin growth factor 1 and leading to signal transduction changes in long-term hematopoietic stem cell and the niche cells. So I conclude that aged hematopoietic stem cells are different biologically behavior than the younger, with many activities like reduced homing capacity, reduced proliferation capacity, reduced naive and B cell number, myeloid bias, and several important mechanisms are already been identified. The epigenetic changes, the impaired autophagy, the impaired cell polarity, higher inflammation, and the reversal of the aging is a newer field of research and shown particularly with the casein and the rapamycin in the experimental use. Thank you.
Thank you very much. You'll all agree with me, ladies and gentlemen, that he's given you an exhaustive review of a difficult topic on the aging hematopoietic stem cells and hemolymphopoiesis and its reversibility. Traditionally, there are no questions entertained in this session, but I definitely would like to highlight that he's actually touched on the biological mechanisms, how an aging cell is differentiated from a younger cell, and the mechanisms involved thereof at the cellular and at the molecular level. And I must congratulate Dr. Pati for an exhaustive review, and on behalf of my co-chair, Dr. Pranta, and myself, I would like you all to actually join me in giving a big hand for this lovely talk. Thank you.
Thank you.
I thank Professor Pati and the chairs for this Malti Satya oration session. We will now adjourn for coffee, but a few announcements before that. There are limited seats available for Meet the Professor session. The delegates who are interested in interacting with these experts over lunch, please write down your names on the boards near the registration counter. All the delegates whose abstracts have been selected for oral presentations and for poster presentations, kindly upload your slides for the orals and display your posters in your allotted slots. Please reconvene at 10:50 a.m. as we will start the next sessions at 11 a.m. Thank you.
A very good morning, dear delegates and speakers. This is indeed a much awaited session on primary immune deficiency disorders, and it promises to be an exciting one since there's a lot of work going on at present all over the country. And although a lot more needs to be done, there is a lot which has already been done, and it is not rare at all. So over to my co-chair to introduce the first speaker.
I invite Dr. Mukesh Desai, the first speaker, to the podium to have a talk. He needs no introduction. He's a hematologist, immunologist, professor of pediatric hematology and oncology, chief division of immunology, B.J. Wadia Hospital for Children, and his areas of interest includes primary immunodeficiency. Over to you, Dr. Mukesh.
Good morning, everybody. Well, I'll start my talk on a clinical approach to primary immunodeficiency disorder. Just to pay my respect to my teacher, Dr. Karim Boy, who at the age of 77 thought she has developed the Department of Pediatric Hem-Onc. Now she should go on and develop a division of immunology at Wadia Children's Hospital. She literally pulled us into it, and but for her, we wouldn't be there. This is the website we have where you can have normal values for lymphocyte subsets. You can have other important instructions which are there for PID, which you can go through. The basic premise for making a diagnosis of any PID is to ask only one question. Once you have made a diagnosis, you need to ask this question: why has this child developed this problem? And if you probe a little more into details, you will probably find the answer. Say you have a patient who comes to with a pneumonia, you need to ask why this particular person has developed pneumonia and find out the reason. So this is the anatomy of my presentation. I'll talk to you a little bit about changing concepts in primary immune deficiency, give you an idea about what we think about PID and what is the clinical spectrum of PID you are likely to see in your clinical practice. We'll talk to you about expanding scope of primary immune deficiency and when to suspect PIDs, and we'll talk about some unique PIDs and give you a simplistic approach with a carry-home message. So friends, whenever we think of PID, we think of infection. Infection which is either very severe, infection which is recurrent, infection which is difficult to clear, infection which is persistent, infection which is at unusual site with unusual organism. All of you would agree that this will bring the thought of primary immune deficiency in your mind. But please remember, patients who have got autoimmunity can also be manifestation of primary immune deficiency. Some patients can also come to you with malignancy. We all know that immune system is extremely important in controlling rogue cells which our body develops, and failure of immune system results in even malignancy. But today we understand that the scope of primary immune deficiency is expanding. Today we know that hemophagocytic lymphohistiocytosis is nothing but a primary immune deficiency disorder because of defect in NK cell and cytotoxic T cell function. We appreciate that D negative HUS is also a manifestation of PID because of regulatory complement defects. Crohn's disease or inflammatory bowel disease is also a manifestation of primary immune deficiency disorder. Dr. Casanova's group has also shown that herpes simplex encephalitis, even brainstem encephalitis, is a primary immune deficiency disorder with genetic defect which make you susceptible to it. And we also include the autoinflammatory disorders as part of primary immune deficiency disorders. So there is a sea change which is taking place. 10 years back, there were 150 primary immune deficiencies. Now there are more than 350 primary immune deficiency disorders. The concept of primary immune deficiency is changing. Today we believe that even a single episode of a life-threatening infection could be a manifestation of underlying PID. So So if you really see, today the concepts are changing, that we would find that PID instead of a rare disease would be a much more common disease. It would be more sporadic without a family history. It may be seen more at different age group, especially in adult, and at the phenotypic level, you may find they may have limited repertoire of infection, they would have low penetrance, and they may just manifest to you with a single episode of a life-threatening infection. So today, conceptually, we believe that PID, instead of those rare disease, may be much more common than what we think. And it may, in fact, may be one of the commonest disorders you may be seeing in your clinical practice. So let me take you through some of the spectrum of PID which you are going to see in your clinical practice. And this is a slide which I always show. This is a patient who came to us for pneumonia and developed such horrendous looking IV site infection. We biopsied it. It showed a fungus known as Basidio bolus. We didn't know what the fungus was, so we Googled it and found this fungus not uncommon in our country. And then we asked that single question which I have asked you, as why this child should develop this kind of infection with such a fungal infection. And we worked him up, and it turned out to be a case of chronic granulomatous disease. Here is another example of a lady at the age of 15. She already had a liver abscess. She already had a pneumonia. She had multiple infections, telling you that she needs to be worked up for an underlying PID. Now, we have a dictum that if you have a liver abscess, you have a lung abscess, or you have an osteomyelitis, you have to do an NBT to rule out a chronic granulomatous disease. So this patient also turned out to be a case of chronic granulomatous disease. If you ever see something like this, very horrifying looking infection, but absence of pus. And if I tell you the WBC count was 80,000 with 90% neutrophils, all of you will say this is leukocyte adhesion deficiency type 1, and this is what this patient had. And there was another SIB who also had a similar problem. This is just to show you a patient of mastoiditis who had been operated, and post-operatively 10 days later, even the wound is not healing. If you have defect in phagocyte, you will find that there is defective wound healing, which is something which is a characteristic of phagocytic defect. Those patients who come to you with a B cell defect often have infections above the diaphragm, so recurrent respiratory tract infection, pneumonia at different site. You have sinusitis, otitis media, you suspect a B cell or a complement defect. And this can be an extreme effect of B cell deficiency, which you can see with bronchiectasis. Peculiarly, patients of B cell defect are prone to enterovirus infection. So this is a patient of XLA who has come to us with an enterovirus infection. You can do something about this. You can give them high dose IV gamma globulin, which we are giving to one of our patients with some dramatic responses. 1 gram every week, 1 gram per kg every week, and you can see a response. They also come sometimes with autoimmunity. Here is a patient of an hypogamma-globulin coming to his alopecia totalis, which recovered with IV gamma-globulin therapy. If you see a patient like this, who at the age of 40 came to us with an hyperextensible joint, an hematocele, and a facies which is very characteristic, all of you would suspect an hyper-IgE syndrome because of autosomal STAT3 mutation. This is a patient who has come to us with a BCGosis, but this child had no failure to thrive. She had a normal lymphocyte count and a normal lymphocyte subset, so she was not a SCID. So she turned out to be a case of Mendelian susceptibility to mycobacterial disease, which we are increasingly diagnosing in our country. If you ever see a specimen which has got such exuberant amount of AFB, you need to suspect an underlying primary immune deficiency. Multifocal bone tuberculosis. If you ever see a multifocal bone tuberculosis, you must suspect a partial dominant interferon gamma receptor defect or an autosomal STAT1 defect. For this patient, we were suspecting a partial dominant interferon gamma receptor defect. Taking it further, here is a patient who came to us for a PUO at the age of 48. His lymph node biopsy showed a histoplasmosis, and he gave a history that he had about 6 episodes of salmonella in childhood. So like salmonella is also an intracellular organism, just like Mycobacterium tuberculosis, you have to rule out an IL-12-23 interferon gamma loop defect. If you ever see somebody coming to you with this kind of disseminated tuberculosis infection, you know that this patient is immune deficient and needs a detailed workup. Now, susceptibility to tuberculosis need not be present only in childhood, it can be present in adult, it can be acquired also, and this is an example of patient who has a neutralizing antibody to interferon gamma developing a non-tuberculous mycobacterial infection. If you ever get a non-tuberculous mycobacterial infection outside the setting of a lymph node or a wound site infection, you have to rule out an IL-12/23 interferon gamma loop defect. Post-vaccine, this child develops such vaccinia. It tells you this child has a T-cell immune deficiency. Recurrent herpes zoster infection. Whenever you see something like this, you have to rule out a Docket deficiency, which is sometimes a very characteristic manifestation of Docket. This is another classical presentation of a Docket deficiency. You see disseminated molluscum contagiosum, you have to do an IgE levels. The IgE levels are high, it will tell you, virtually tell you that probably you're dealing with a Docket deficiency. And here is just to tell you how much our orientation is not there for PID. This is a 70-year-old gentleman who had 3 episodes of brain abscess, and he grew nocardia. The organism is telling you that there is something wrong with this patient and he's immune deficient. When we examined his CBC, his ALC was as low as 50 and 100 all along. So he had probably an idiopathic CD4 lymphopenia, which was the reason why he developed this kind of infection. You see this kind of chronic mucocutaneous candidiasis, we know that there is defect in either Th17 pathway, and we need to work this patient up. Autoinflammatory disorder. Here is a child who came to us with fever, and he came to us with rash from day 1 of life, developed some joint swelling. This is a characteristic presentation of an autoinflammatory disorder. And here is a child who developed an forearm abscess. This abscess was drained. He was given a course of antibiotic, and he used to keep getting these abscesses. Subsequently, the father realized that whether you give him antibiotics or you don't give him antibiotics, his wound would heal itself. And then one day he developed such pyoderma gangrenosum-like lesion. We suspected a PAFA syndrome in case, which we could prove by doing a mutation analysis in this case. So this is another extreme example of an autoinflammatory disorder presenting with such extreme presentation. So this is just to show you in a cartoon form various autoinflammatory disorders which can come to you, and this is a patient who had a PAPA syndrome. Now, if you see a child who comes to you with lymph nodes like this and you can notice there are some petechial lesion, you would automatically say this is probably either a leukemia or an ALPS. This patient turned out to be a case of autoimmune lymphoproliferative syndrome, so manifesting with autoimmunity in node, cervical node. This is a characteristic nude mice phenotype with absent thymus with alopecia totalis because of FOXP1 deficiency. You have now extreme variability in PID, so if you see palmoplantar keratosis, you must suspect a Papillon-Lefebvre syndrome. You have pigmentary dilution disorders like Griscelli with HLH, which very often come to us with HLH. So this is the whole spectrum which we are seeing day in and day out at our immunology clinic. But is there something more which needs to be discovered? The answer is yes. Here is a patient who came to us with disseminated cysticercosis. So you can see the kind of dissemination he's got. Now, without being a clinician also, you can say that this patient, there was something wrong with him. He has an underlying immune deficiency. We have sent for a whole exome sequencing to find out which gene is defective in this patient. Now, this is the story of another 16-year-old boy who came to us with a nasal mass. He had a nasal mass which was extending and eroding to the base of the skull. It was extending into the retrovertebral region, causing proptosis. This was excised at Tata Memorial Center, and instead of a malignancy on the histology, it turned out to show hyphae consistent with aspergillosis. So when you see something like this patient was treated for 6 months, and then he developed a mediastinal mass, which was also thought of as a lymphoma, and a biopsy was done. The biopsy showed aspergillus hyphae consistent with aspergillosis. Now, if you ever see an aspergillosis in a non-neutropenic setting, you have to rule out chronic granulomatous disease. That is the dictum. So we were very excited. We thought this is CGD without any doubt. And unfortunately or fortunately, his CGD workup turned out to be normal. So we really don't know why does he have a susceptibility to aspergillosis. So here is a patient where you have an opportunity to find a gene which could make the person susceptible to aspergillosis. So there are many Mendelian diseases yet to be discovered. They say there are more than 10,000 Mendelian diseases which are yet to be discovered. And we have an opportunity to discover some new diseases, put a new gene and probably put a name to that ourselves. Now we all understand that infections were considered environmental in origin. But today we know that the environment is the same for everybody. Today we understand the bug is changing, but the bug is same for everybody. But if a person responds differently, we believe that the person is responding differently because his immune system is responding differently to the bug. So we have come down to the genetics of infectious disease, and we believe that if any person responds differently to an infection, it is probably because he has an immune defect because of which he is responding differently. Now, when we talk of immune deficiency and infection, we always think about multiple infection. An immune deficient person is prone to multiple infection. Can you have an immune deficiency where you are prone to a limited repertoire of infection? The answer is yes. And the classical example is C5 to 9 deficiency, where you are prone only to Neisseria meningitis infection. Another classical example is XLP, where the boy is fine, and he contracts an EBV infection, goes into fulminant EBV, can develop HLH, and go on to develop even a lymphoma or a hypoplastic marrow or a CVID-like presentation. This is because of a SAP deficiency, where they are particularly prone to EBV infection only. If it's a female patient, you have to think of an ITK deficiency. Now there are more than 15 genetic defects which make you susceptible to only EBV infection. I've already shown you this slide showing you that genetic susceptibility to mycobacterial disease because of IL-12, 23 interferon gamma loop defect. You are prone to intracellular organism related infections. You are prone to NTM infection, you are prone to tuberculosis, you are prone to non-typhi salmonella. You're prone to recurrent salmonellosis, nocardiosis. You're prone to klebsiellosis, histoplasmosis, and maybe in India, Leishmania donovanis. So this is the organism which you will be prone to. Now we all know that the hemopoietic system is the mother system for immune system. The immune system arises from the hemopoietic system. Can you have a non-hemopoietic PID? The answer is yes. Here is an example where you have only a defect in the skin, in the avar, and that gives rise to susceptibility to warts. This is what we believe today, that inborn errors of immunity to infection are more the rule rather than an exception. So if a person responds differently, he is responding because there is some defect in his immune system. Can we have immune defects where you are more susceptible to common organism, day-to-day organism like staph and pneumococcus? Molecules shown in red over here, the IRAC4, the MID88, the Nemo gene, and the STAT3 make you susceptible to staph and pneumococcus infection. So here is an example of a child who has got a liver abscess, but he doesn't have very severe signs of systemic inflammation because IRAC4 deficiency affects the NF-kappa B pathway and the inflammatory signs are subdued. Here is another example of an hyper-IgE syndrome where you're seeing pneumatocele and cold abscesses, which is characteristic of a STAT3 mutation. Just to show an example of DOC8, this is a patient shared by Dr. Manisha, where you have this kind of disseminated molluscum contagiosum, IgE level high, and this patient had a DOC8 deficiency, as you can see. Dr. Casanova's group has shown that herpes simplex encephalitis is a primary immune deficiency disorder when they did workup for 4 families who had family history of herpes simplex encephalitis. These are the 4 genes which are mutated. They have also shown that brainstem encephalitis is also a primary immune deficiency disorder because of defect in RNA lariat debranching enzyme. So friends, what is the first step in picking up a diagnosis of primary immune deficiency? First step in picking up the diagnosis is to think of PID. The second step and the third step is also to think of PID. So you need to be highly sensitized to suspecting PID. And today people believe that every child who lands up into the PICU probably is an immune deficient child whose immune deficiency we may not be able to prove today, but in future we might be able to prove. We just did a data analysis to see what was the distribution of immune defects, and we found that we had a very low percentage of B cell. Probably we have come out from a hematology unit, so we pick up a lot of HLH, so we have large number of NK cell defects, but I'm sure we are missing large number of B cell defects in this country. These are the Jeffrey model criteria which is available on every website which tell you when to suspect primary immune deficiency. These are Western criteria. I'm sure the Indian criteria would differ and we'll need to find the Indian criteria. They have also come out with specialty-wise criteria. So a cardiologist, when he sees a particular set of patients, needs to refer that patient to rule out immune deficiency. For every specialty, they have come out with criteria which are available on their website, and they are very interesting to know. Knowing the organism is very often the clue to suspecting underlying immune deficiency. So at Vardy's Children, we send every tissue we take out, we send for culture. And this example will show us, this is a boy who had a BCG at birth. He was diagnosed as CGD, was to go for a transplant, but couldn't go for a transplantation. So he came back to, was referred to us. So when we did his NBT again at our place, it turned out to be normal. So we didn't know what was the diagnosis. And he used to keep coming to us with this kind of nodes. So one day we decided to biopsy the node and send it for culture. When we biopsied the node and sent it for culture, it grew an organism, non-typhi salmonella, which told us that yes, he has got a defect in IL-12/20 interferon gamma loop. And since IL-12 receptor beta-1 is the commonest defect which is seen.
Excuse me, sir. We are at the end of time. Can you
I'll just
wind up
summarize
in a minute?
for you.
Yeah.
Which told us that he has an IL-12 receptor beta-1 defect, which we molecularly confirmed. So friends, the spectrum of primary immune deficiency is changing tremendously. The concept is changing tremendously. Today we believe that every child who comes to you with a severe problem, you have to look beyond the immediate diagnosis. And the one question which you need to ask is, why has this child developed this problem? And probe a little deeper. You will find the answer in that. It will lead you to an underlying immune deficiency. Thank you very much for giving me a very patient hearing.
So we hope this session will help in a permanent change to our attitude towards PID. We can take one question. Well, if there are no questions, we thank Dr. Mukesh Desai for this very colorful and interesting presentation. Thank you, sir. We move on to the next session.
Yeah, I invite Dr. Eunice Sindhuvi for her next topic, Laboratory Approaches to PID. Dr. Eunice Sindhuvi is a professor in the Department of Hematology, CMC Vellore. She completed her PhD from CMC Vellore, and she's a laboratory faculty and mentors PhD students. She has received various awards such as Linus Palmer Award and CDSC Fellowship. Her areas of interest include immunodeficiencies and iron metabolism. Over to Dr. Sindhuvi, please.
A very good morning. Today, after that wonderful clinical presentation of PID, I'll be giving a brief overview of laboratory approach to PID. As we all know, primary immunodeficiency has been described as diseases caused by one or more defects in the immune system. And this all starts in the hematopoietic stem cells, which give rise to the different lineages of the hematopoietic system. And as we know that a defect in any one of the steps during lymphocyte development leads to different diseases of the immune system. And as already told earlier, primary immunodeficiency is not only in the immune defect, but it presents as a multifaceted presentation, including malignancies, lymphoproliferation, infections, and autoimmune diseases. So, the classification of PID is keeping on changing, and with the latest classification, it generally says that the major classification is a combined deficiency of cellular and humoral immunity, and there are classifications based on syndromic features, complement deficiencies, autoinflammation, and based on the lineage of the cells involved, you can have phagocyte functions and other cell lineage defects. So immunodeficiencies affecting cellular and humoral immunity are the severe form of the immune deficiencies. So here, this classification, the 2017 classification classifies this combined immunodeficiencies based on the CD19 levels. So if you have a CD19 level with a T negative and a B positive, then you can have different classifications based on the different genetic defects involved. And if your CD19 is low with a T negative and a B negative, and these are the other different diseases which can fall into the category. This is based on the age-dependent subset analysis, which we can come into this conclusion. The predominantly antibody deficiencies is the other major group of primary immunodeficiencies. And based on the immunoglobulin levels and the B cell levels, you can classify them as B absent or B greater than 1%. B absent or B less than 1% of the total lymphocyte count. And the most common, the B cell defect is the BTK, which we see. So this, based on the literature, we do not have enough Indian data on this, but data is coming up, and we see that antibody defects are the major constituent of the primary immunodeficiency, followed by cellular and antibody deficiencies and phagocytic cell deficiencies. So PID has seen an exponential growth in the area of clinical immunology, and the enormous clinical and laboratory heterogeneity in PID makes a diagnosis of PID a challenging. Laboratory diagnosis is a challenging feature. The first line investigations include a CBC, a quantitative immunoglobulin measurements, a vaccine response, and if it is indicative of a T cell, a skin testing for delayed hypersensitivity. So what you can see in a CBC, if it's a neutropenia, you can think in the direction of congenital or cyclic neutropenia. And if it's a lymphopenia based on the lymphocyte count at different with concordant with age, you can think of a T cell disorder. And if you see leukocytosis in between infections, then it can point towards a LAD. And if you look at male infants with thrombocytopenia, with a probable diagnosis of Wiskott-Aldrich syndrome, some features of anemia, and it can lead a probable of CVID, and unusual Howell-Jolly bodies with asplenia and impaired splenic function can tell of Chediak-Hejai syndrome. So coming to the immunoglobulin levels, if all the immunoglobulin levels are low with the antibody deficiency, and the vaccine response, this table shows the different antibody responses and the time frame which we expect a peak antibody response at different time intervals for the different vaccines and the levels. So this can be used to, which is an indicative of the PID. The skin testing for delayed hypersensitivity is a test for a T cell function. And if there is a lack of response at 24 or 48 and 72 hours, it does not confirm ID in previous exposure to Candida, but a positivity excludes a T cell disorder. Coming on to the second line of investigations, this has to be decided based on the history and the continuation of the first line investigations. Like the second line of investigations can be a lymphocyte subset analysis, and if it is suggestive of a phagocytic defect, then we can go for DHR, and if it's a LAD, then you can go for CD11 and 18 assay. If you're thinking of HLH, serum ferritin and triglycerides can help. So if it is a T cell lineage, so there are for different cells, we can use different tests to evaluate their function. And as we have already seen, the number of T cells can be reflected in the total lymphocyte count, and a quantitative defect by doing a different subset of T cells by flow cytometry. And also the functional, even though sometimes the numbers are normal, the ability of T cells to respond to different types of stimuli, including mitogens and antigens, can be defective. And T cell proliferation and production of various cytokines such as interferon can also give a clue to the functional part of the T cells. And TREC assay, which is excision circles from the T cell receptors, can also be used as a marker for T cell function. The neutrophils, if the first line tests indicate a neutrophil defect with a low neutropenia, then the major diseases involved in this are the CGD and the LAD. And this figure shows a NBT, which is familiar with most of you here. The normals, the wild type, the wild type shows the uptake of the dye, whereas the CGD patients are not able to take up the dye. And a DHR assay where the cells are treated with DHR, the oxidative the oxidative burst of the cells after stimulation in the control, you can see an increase in the uptake of the dye, whereas the patient, you cannot see an increase in the uptake of the dye. Complement deficiencies are one of the part of the PID systems, and they are assayed based on the CH50 assays, and the alternative pathway of the complement can be assayed by the AH50 assays. Flow cytometry plays a major role in the diagnosis of primary immunodeficiencies, and as I already said, the lymphocyte subpopulation and subset analysis can give rise to a indication of the cell lineages involved. And as we have seen, the neutrophil oxidative burst can indicate a CGD. And also, if we can look at the expression of several cell surface markers and intracellular markers for a probable diagnosis, like CD11 and 18 for LAD, and CD40 ligand and 40 for the hyper IgM. The memory B cells for CVID, and ALPS, double negative T cells, TNF alpha assays, and the T regulatory assays, and the perforin granzyme assay for HLH. Even though there are a lot of laboratory tests involved, the overlap of clinical symptoms between the primary immunodeficiency diseases as well as the major limitation of the laboratory-based assays to get the proper reagents and expertise fail to identify affected individuals, and the interference of confounding factors make these laboratory tests not a very definitive one. Genetic diagnosis plays a pivotal role in confirming the clinical diagnosis of PID. And as we all know, it's a heterogeneous group, and as already mentioned, it's a group of more than 350 diseases, and more than 350 genes are being implicated in the genetic defects in PID. So genetic diagnosis of PID is also challenging. You can have multiple genetic defects, but one phenotype. An example is chronic granulomatous disease, where mutations in different genes like CYP-BB, CYP-A, and NCF124 can give rise to chronic granulomatous disease. And it even more becomes challenging with more than, every year there are more genes being added to the panel, added to the genetic defects in PID, and it is like 10 novel PIDs are discovered annually. If you look at the methodology, what will be the best for doing a genetic diagnosis of PID? Sanger sequencing is, even though if you know the exact genetic gene involved, then it is better, but it is, most of the cases, it's slower and more costlier than a next generation sequencing. Several people have used targeted panels for genetic diagnosis of primary immunodeficiencies, but with a number of genes being added to the panels, and more people prefer exome sequencing for a genetic diagnosis of primary immunodeficiency. So the next two slides, I'll be briefly taking you through our approach for genetic diagnosis of PID in our lab. So with a subset analysis, if you have a reduced immunoglobulin along with a CD3 lymphopenia, the T negative, B positive, NK negative, the IL2RG is the most common genetic defect involved. So we sequence this gene, and if negative, then take for NGS. And this group directly goes for NGS, and the T negative, B negative, NK positive, the RAG1 and RAG2 are small genes. So we do the Sanger sequencing, and if negative, then taken for NGS. And if it's a reduced immunoglobulin and you see a CD19 lymphopenia also, we first do the BTK, and if negative, then taken for NGS. And if the subset analysis is non-contributory, then we think of a phagocyte defect and other things, and we take it for NGS. And basically, if you have a normal subset with normal immunoglobulin levels, with neutropenia and other features which are suggestive of HLH, we have 3 genes, and neutropenia with maturation arrest, we first screen the Elaine gene, which is the most commonly involved in congenital neutropenia, hyper IgM, CD40 and 40 ligand. And if you see thrombocytopenia and eczemia, we do Viscott-Ulrich syndrome gene analysis, and then all the others are taken up for NGS analysis. So this is the brief overview of next generation sequencing, which we also follow. We take 250 to nearly 275 genes are there in our panel for NGS. So we do the sequencing. Then we do alignment after all the QC check has been done, and variant calling and annotation is done. And then we do the allele frequency check if it's a minor, based on the minor allele frequency, and if it's already a reported variant. And we do make use of several bioinformatic tools like SIF, Polyphen to find out the causative genetic variant. And it is finally confirmed by Sanger sequencing, and ideally functional assays will be required to make a causality to the genetic variant identified. So this table shows the list of mutations identified in our center based on Sanger sequencing as well as our NGS analysis. We took a series of 81 patients with primary immunodeficiency, and we could identify mutations in 11 of the BTK and 9 of the HLH, and these are there. And apart from this, we could identify mutations in CD40 ligand, TBX1, DOC2, and other genes involved in PID. So one thing to remember is out of the 81 patients which we had, we could, using this methodology, we could identify the genetic defect in 39 of the cases. So yeah, even with the genetic diagnosis, the literature also reports that 15 to 40% we can arrive at a genetic cause. This is because there are increasing number of genes being added. And even if you find a probable damaging genetic variant in a gene which is not related to PID, it's very difficult to assign causality. Is it because of that? So, and there is an increasing load of variants of uncertain significance, which which needs furthermore studies or furthermore literature in this area to assign causality. And finally, functional assessment of these variants is very crucial to whether it's affecting splicing by protein assays or RNA-based analysis to assign causality. So this is a brief overview of laboratory approach to PID. Thank you.
Thank you, Madam, for that exhaustive presentation and for finishing well ahead of time. We can take a couple of questions. Would anyone like to ask anything?
Dinesh Burani from Rajiv Gandhi. How much, so you are involving 250 genes, and how much is the cost for this? And is it available to the others to send the samples?
So we recently started doing this panel, and it roughly cost around 16,000. The actual cost comes around 16,000. So the actual test cost comes around. We are in the standardizing mode, and probably will take some more time to accept samples from outside.
We would like to have a couple of more questions because we have quite a lot of time. And if anyone would like to ask a question of the previous speaker and did not want to do, was thinking about it, they can do so now. So either questions to Dr. Yunus or to Dr. Desai can be taken.
Hi, Satya Yadav from Gurgaon. So you mentioned about the congenital neutropenia also, that Elaine mutation and other things. So any experience with GATA2 mutation? Because GATA2 deficiency has very wide spectrum. It can have aplastic anemia, congenital neutropenia. It can present as leukemia. It can present with immunodeficiency. So I think that is missing out in the presentations, and I think this is a big disorder which is being identified nowadays. Thank you.
So I have not shown the data from our center, but in ELA negative patients which we taken up for NGS, we have seen cases of GATA2 deficiency being reported in the population.
Please use the mic.
You could identify only about 29 patients out of 82 patients, some genetic defect. What happened to the remaining patients?
So there are some, in some cases, there are variants where, it is a pathogenic variant, but in a gene which is not been involved in PID. So there are some problems like that where we could not assign a causality. So even in the literature, if you look at the data in many centers, you see that out of all the primary immunodeficiency cases, they could identify a genetic defect which could finally link to that thing in only 15 to 40% of the cases. So that is still a limitation of the...
Thank you.
Any more questions? We could still have a couple of them. Madam, how do you diagnose microplatelets? Because we often see that the counters are not sensitive enough to pick them up. So how do you actually diagnose microplatelets? Because if you miss them, you could be missing a case of Viscott, isn't it?
So we look at the MPV. So that's the only thing which we...
Okay, thank you. Any other questions?
Ask
Yeah, sure.
previous speaker. Means you have a 10 points to say this child should be evaluated. Do we have an Indianized do we have a something? You said PICU, every child should be investigated, but at least some minimum criteria. These patients should be investigated for PID.
Well, I think currently, philosophically, we are following this policy that any person who comes to us with a severe infection or multiple autoimmunities, we look for an underlying cause. We look for a PID. We are very liberal with investigating patients for PID, and we feel that when we investigate them more and more, we pick up more diseases. We pick up more PIDs. So it's just a question of sensitization. Say, for example, you see an NTM infection, which is referred to you, which is not a nodal NTM, or it is not a wound site infection, you have to rule out a PID. They have to have a defect in IL-12/20 interferon gamma loop. If they don't have, then they probably need to go for a research setting investigation. So anybody who comes to with more than one episode of pneumonia, 2 episodes of pneumonia, we investigate them thoroughly. Otitis media, unfortunately, we don't get referrals directly, but the literature, anybody with more than 4 episodes, we would investigate the patient. So at Wadia Children, the organism sometimes gives us a clue to work up. For underlying PID, as I told you, NTM, that way if you see a grow a nocardia or Serratia marcescens or an Burkholderia cepacia, you have to rule out a CGD. Aspergillosis in a non-neutropenic setting, we always rule out a CGD. So we are very sensitized to investigating, and we are a little liberal in investigating.
Thank you, sir. So you have made very important statements like even a single episode of a life-threatening infection warrants investigation for a PID, and it could possibly be the commonest disorder in clinical practice, and every child in the PICU needs to be evaluated for a possible PID. So how frequently do you think failure to thrive is taken as a pointer towards PID? And what is the work that's going on in India towards evolution of guidelines of our own to replace the ECID guidelines?
Answering your first thing, I want to just clarify that when you say every child in PICU needs to be investigated, This is just a philosophy, this is a proposition. It doesn't mean that every child in PICU would be a PID. Probably we don't know what the underlying PID is today, but the philosophy is, if somebody has got a severe problem that he lands up into the PICU, he needs to be investigated. For example, you have an influenza virus, severe pneumonia, child lands up in PICU. They have found a defect in IRF7 protein. So if you probe more and more and investigate this patient, some of our dengue who land up into dengue shock syndrome and go into developing severe HLH. We are seeing so many dengues, we go into HLH. I'm sure we need to investigate this patient. There's no reason why they should suddenly go into a shock syndrome and develop an HLH. And sometimes the ferritins are 200,000, which is horrendous. I mean, so there has to be something where they are responding differently. So this is the philosophical proposition on which you should investigate. And maybe today you don't have the means to make a diagnosis.
True.
In future, you certainly would probably lead to a diagnosis.
Thank you.
Can I ask a question, ma'am?
Yeah.
Again, Dr. Mukesh, and in fact, Eunice can also step in. See, I think we have sensitized enough in the last few years, and things have changed. The workups available have changed. More and more we picked up, but I think we still are picking maybe less than 1% of what we have in our country. So are any attempts of, I know, I mean, you guys are doing a great job in NIH and, you know, supporting a lot of other centers, but are there any steps from especially from the Immunological Society to have a more, I would say, formalized approach of working up these? We suspect a lot, and then the problem is by the time you get to the diagnosis, either the child is no more there, or you haven't got the means to do it. So I think there's lots to be done in terms of educating in that context, as well as have some referral units to be able to, because every place cannot have that, the gamut of investigation which is required. To have that, and any efforts towards that.
Dr. Mukesh, please.
Well, I can answer your first question where you said about sensitization. So we, as a society, Indian Society of Primary Immune Deficiency is doing a PID workshop every year, which is an introductory course, which is done by Dr. Sudhir Gupta and the Indian Society of Primary Immune Deficiency. It is held at different centers, so we can sensitize different parts of the country. We are having every 2 years an annual international conference on primary immune deficiency. This time is going to be in March 9, 10th, 11th, which will be in Mumbai at the Hotel Leela. And we'll have about 20 faculty which will come from abroad for that. And these are all top of the line faculty. Then we have, at the moment, proposed to some companies that we should have a module where we should start teaching about immunology to all our residents, to all our MBBS. And the company is very keen, and so I'll need all of you people's help. I'll be writing to you about that. I just had a meeting right now about an hour back. So we can develop a module which is all India module, something very similar to what SIOP had done with the Indian, our PHO chapter. We can have a similar module. I have a feeling that if we can do that for our undergraduates, for our postgraduates, we will take the level of medicine in all specialty 10 notches higher than what we are today. And I'm sure the younger generation is extremely bright, extremely intelligent. Just imagine if they have this information and knowledge today, at that level, the level of medicine will change. So it is the onus is on us. Let's not fail them. So let's all get together. This is an opportunity for us to get together, to devise this. So we are in the process. So during this meeting, we will be having a meeting one day prior on Friday on this. Before that, I'll be writing to you and we'll do some brainstorming on this, how to go about and put this module in place so that we can teach. Because if you go to Necker Hospital, a resident rotates in the immunology division for about six months. They don't send their transplant to a hematologist. They do it themselves. They got 8 wards for immunology.
Thank you,
That's
sir.
the way you can bring out such research.
Thank you, sir. So on that optimistic note, let's move on to the next topic. We thank profusely Dr. Desai and Dr. Eunice. Thank you.
Yeah, the next person to come and speak is Dr. Shantanu Sen. He is a consultant and head of pediatric hemato-oncology and stem cell transplantation at Kokila Ben Dhirubhai Ambani Hospital, Mumbai. The pediatric oncologist has extensive experience of working with children with various cancers and blood disorders for over 12 years in the UK. He has worked at the Royal Marsden Hospital in London treating children with cancer. His area of interest include pediatric blood disorders and pediatric cancers. Over to you, Dr. Antanos.
Thank you very much for that very kind introduction. My previous speakers have made my job much easier. It's always such a pleasure to hear Dr. Mukesh Desai speak on PIDs, and my only regret is that I would have loved to hear him speak a little bit more. And I really thank Dr. Yunus to kind of like explain to us how do we diagnose these patients of PID. Now, when it comes to treatment, we can probably just finish the treatment possibly in one line and say that if you suspect a PID, transplant. But it probably is a little more complicated than that. If we look at what is the status of transplants, PID transplants were one of the first diseases that were treated by using a stem cell. And the first one took place in 1968, where the first patient with a severe combined immunodeficiency had a stem cell therapy. 1973 was the year when the first unrelated marrow transplant was done for a kid, followed by 1980, when a haploidentical transplant was again done for the same disease. 1995 is quite an important year because this is the first time that gene therapy was successfully used to treat a patient with ADA deficiency in SCID. As you heard, there are more than 350 distinct genes that have been identified for which has been implicated for various PIDs. And as Dr. Desai has said, the number of diseases that we are identifying with primary immunodeficiencies are actually expanding exponentially. When it comes to transplant, we are getting better at it. But make no mistake, as transplanters, myself, Sunil, and others in the dais will tell you, that PID transplants possibly are some of the most challenging transplants that we take on. In spite of that, internationally, survival figures have touched nearly 90%. We heard about how NGS is a fantastic tool to try and diagnose these diseases, but we also now understand that it also has its limitations. At sometimes that even using NGS, we may not be able to identify exactly what the deficiency is, what the underlying condition is. The other problem with PIDs is that these patients are obviously young, they have persistent infections, they might have autoimmunity, they might have end organ damage, which all makes it very difficult for us as transplanters to take them on. What I thought is, rather than talking about diseases and how to transplant, we'll talk about a few specific problems that we face. And these conditions, these considerations, we'll talk about patient selection, how do we select a donor, a little bit about conditioning regimes, graft selection, degree of chimerism, and one of the major problems we face when we treat these patients are viral infections and GVHD. And if I have time, we'll talk a little bit about specific of SCIDs, CGD, and WAS. So, which are the immunodeficiency diseases, the primary immunodeficiencies for which you really think about transplant? The first one up there is a SCID, a severe combined immunodeficiency. Now, these patients will present early with multiple infections. They are sick, they will keep on getting infections, and without a definitive treatment by doing a stem cell therapy, they will die. So this is what, at least when I was working in Newcastle in the stem cell unit with immunodeficiency unit, we used to call it the emergency transplant, that if we got a patient referred with a SCID, we would all say, okay, this is what this patient needs to be here now. And we need to get going right away so that we can start off the transplant process as soon as possible. Every other patient takes a backseat. So if you have a SCID, that is a transplant emergency. However, if you have a SCID with an ADA or an IL-2 R gamma deficiency, then these have an option of treatment with gene therapy, should that be available to you wherever you work. Then there are the more severe T-cell lymphocyte immunodeficiencies. I put them out there like a Wiskott-Aldrich telangiectasia. So even in these patients, outcomes are poorer if you do not transplant. And finally, you have conditions such as CGD. which is basically where you have more of a defect in the B cells or a lymphocyte addition. Now, there is some thoughts that with these diseases, whether conventional treatment with antibiotic might be helpful, but even with these diseases, there is enough data to say that if you transplant, they do much well. Now, with a CVID, common variable immunodeficiency, usually we would not consider a transplant, and these patients are all on immunoglobulins, antibiotics, plus or minus a little bit of immunosuppression. But even in these patients, the prognosis can be a little bit questionable. And so with these patients, we have to think carefully and certainly think about whether a transplant can be helpful. Some of these patients may not have a genetic diagnosis, which makes your treatment plan even more difficult. And finally, we'll come to this problem of adult patients. More and more of these patients who had PIDs will grow on to adult. And by this time, they might have managed their pediatric time period with conservative management. As they are growing older, they would have more problems. So these are the transplants that our adult colleagues are taking on. And even in these patients, success rates of more than 85% have been reported. We have some other conditions in which it might be appropriate to transplant some of these patients, but possibly not all. And then there are other therapies which are coming on, such as with the JAK inhibitors, ruxolitinib has shown to be very useful. For CTLA4 ligand deficiency, abatacept, etc. I've put up there. So the basic thing, whenever we're thinking of doing a transplant for a PID, is earlier the better. This kind of like is a very basic truth whenever you're dealing with. And the second is that not only age, it's also the absence of infection. The kids who already come to us with lots of infections already have a degree of end damage. These are the kids who will not be able to get rid of these infections. So again, it's a request to all my other colleagues is refer these patients early as possible. One thing that sometimes referring pediatricians kind of think that child has an acute infection, let him get over it till we refer. The problem is that these patients will not be able to get rid of the infection because of the immunodeficiency, and possibly we just need to find that time window when he's a little bit better and go on with that. So who's the ideal donor? We decided we want to do a transplant. I mean, we can say the best donor for most patients will be a matched sibling. However, there's a problem. One is you can say that most of these families would have a history of consanguinity. So there will be a greater chance of finding an HLA-matched donor within the family. There might be a problem that some of them may not have an identified disease. We don't know whether the potential donor might be a carrier, might have an undefined immunodeficiency, or might even harbor the disease, but they're at a very early stage. So unless we can actually find that there is a genetic cause for the disease we identified in the patient, and exclude that in the recipient, then and only then we should take a family donor. In fact, for a condition like X-linked CGD, it might even be advisable to avoid carrier donors because many of them can grow up to get in future problems with autoinflammatory complications and severe fatigue. So if we do not have a matched sibling donor, which is a problem in many of our patients, smaller families, may not be another sibling, first patient gets a disease, we have to look for a MUD or a matched unrelated donor. Problems internationally is that our Indian nationals on most international registries are very few and far in between, and we have a problem in India that our registries are small. And then we have a very unique problem that even if you find a match, we have a problem with the donors being refusal. However, if we forget all of those and say that if you have a choice between a matched sibling and a very well-matched unrelated donor, 10 out of 10, the outcomes in generally are really quite equivalent. But if we don't have those two options and we want to use a third option, that we want to use a parent, we want to use a haploidentical donor. Obviously, if you're using a haploidentical donor, we can't use it straight away because we need some degree of graft manipulation. One of the most commonly used international methods of manipulating the graft is by doing a T-cell receptor alpha-beta depletion. So what is done is we use this to take out the alpha-beta cells which causes GVHD, but keeping back the gamma delta cells, which are the cells that helps in fighting viruses. In fact, nowadays, you can even expand the gamma delta cells ex vivo and inject that back. And using this method, in most places, more than 76% patients have full donor chimerism, which is fantastic if you have a unit where you have access to TCR alpha beta. To be honest, it's very widely available even in India, and most of our transplant centers can access it. But this is the other exciting new way of doing T-cell depletion of graft manipulation, which is post-transplant cyclophosphamide. Very widely used in India, very widely used in China. The theory is very simple, that we know cyclophosphamide is actually non-toxic to the pluripotent hematopoietic stem cells, but selectively toxic to any recently activated lymphocytes. So what we do, we actually don't manipulate the graft, we just put the graft in the donor straight away, and by day 3, day 4, what happens is the T cells that get activated due to the disparity between the donor and recipient starts to multiply. The cyclophosphamide goes in on day 3, day 4, and that takes out all the activated T cells. Absolutely exquisite way of doing it, and we have a lot of experience of doing transplants by this method among malignant patients, and we are getting more experience of using it in the PIDs as well. So if we consider conditioning patients before we do a transplant, we have to say that what regimes should we do? And one of the more important dialogues that and the way our practice has changed is to think about SCID transplants. To say that does a SCID patient really need conditioning because they don't have T cells. So if we kind of give them any cells from outside, they will not be able to mount much of a graft rejection response by Ts. Now, you can look at the EBMT ESI guidelines, which can be very helpful to decide which patients we'll be treating. But basically, I'll come back to this in a second. Even if we talk about conditioning regimes, the main thought is that should we actually go for a myeloablative or should we go for a reduced intensity? The question is that if you do myeloablative, we have higher rates of GVHD infection organ damage versus reduced intensity, we run the risk of having a graft rejection. And even in this, we have had new drugs that we have been using. We're using thiosulfan instead of busulfan in our conditioning regimes, which has low post-transplant toxicity, good engraftment, good graft function. And then again, we can use ATG. There are also newer ways to condition these patients. And one of the most novel ones that basically has come through literally in the last couple of years is using a combination of GCSF, granulocyte colony stimulating factor, and plerixafor in the conditioning regime. So just to give you a bit of a background, when we actually harvest stem cells for an autograft, we use GCSF and plerixafor to multiply the stem cells, and once we find that peripherally the autologous donor has, or even the allogenic donor's stem cell numbers are very high, we can harvest it. But we can now actually use this combination, and this has been used in cases of Wiskott-Aldrich syndrome, where you give the GCSF from day -8 for 5 days, plerixafor for 3 days from day -6. The thought is, and the theory is, the way it works is that this mobilizes the stem cells from the marrow to the periphery, and the CX4 blockage by plerixafor prevents the stem cells from homing in. The rest of the conditioning wipes them out, and when you put the stem cells in, they home right in to the marrow and start proliferating there. And I thought this was a beautiful way to use drugs in a new way. The other consideration is chimerism, and I'll just take you through it. So whenever we do a transplant, we want to know how well the transplant has been, whether we have been able to get the new cells to work. We can look at whole blood chimerism, which is basically checking how much is donor, how much is recipient. But basically, these are the numbers that are in the whole blood. And it's actually much better if we can break this down into which cells have actually engrafted into the patient. So whereas if we do a whole graft, we can see that if this is the recipient's informative allele, And this is the donor informative allele. We do a whole graft afterwards, we can say, right, the donor is really high, the donor is there, the recipient's low. So with the whole blood, it looks like we've had a very good chimerism. It has been a successful transplant. But then if we can manage to do a split chimerism, and we can actually see that when it comes to the CD3 cells, the recipient CD3 cells are still in a majority, which is basically where we are looking into split chimerism, because in PIDs, the myeloid engraftment is actually extremely important. And we've all faced situations where we thought engraftment was 100%, but not in the myeloid fraction. However, there is a little bit of positive to it, that at least unlike malignancies where we really look at 100% engraftment, or even in thalassemias or sicklers where we really look at a very high engraftment, in PIDs, even a low level of engraftment is actually more than enough to prevent infections. So for a CGD, a 10 to 20%, or an HLH, even a 10 to 20% donor chimerism might be all you need to kind of like protect your child from infections. I'm going to devote a little more time to this topic, which is viral infections. And this is because for PID transplants, viral infections is a major problem. Of course, we do a lot of prophylactic therapy, we do a lot of surveillance, but the issue is we do not still have good antiviral therapy. And T lymphocytes are absolutely essential, so which means that in a post-transplant setting, if we don't have enough T lymphocytes, we are going to run into problem. If we look at what are the usual viruses we get in the transplant world, in the post-transplant setting, we have a lot of CMV, EBV, HHV6, and adeno. Now, we monitor for all of them, and if we find CMV titers going up, adeno titers going up, we will do something about it. We do use antiviral drugs, but problem is that what we don't have is functional T cells. Can we do something about it? Can we actually do what is called an adoptive T cell transfer? And this is possible nowadays, which is basically we can recruit donors for virus-specific T lymphocytes. We can manufacture these T cells, and then we can actually monitor while it's injected. How it's done? There are T cell banks which will identify either unrelated third parties or the actual donor or the family themselves. They are encouraged to donate the T cells. We have to make sure they're HLA compatible, they're seropositive for the virus, and they have sufficient frequency of the antiviral T cells. If we look at third-party stem cell lines at Memorial Sloan Kettering, BCM, Royal Free, etc., they have banks where they have identified a number of EBV-specific, adeno-specific cell lines that are already stored there. So we identify a potential donor, we HLA type him, we make sure that he has been exposed to that, and then we go down the manufacturing. There are various ways of stimulating, which is using collecting the memory T cells, stimulating them in vitro, collecting the CD3, CD4 cells, and then finally capturing them with the cytokine system and injecting them in the donor. Does it work? So we have this patient here who had adenovirus, which basically started from day 14, and this is the adenoviral titers that were going up. At this point of time, around about a month, a donor search was started, and somewhere around here, you can see where the T cells were starting to be injected. You might say by this time the adeno was already going down, so maybe not sure how much it had helped, but you can see that after injection of the adoptive T cells, the T cell numbers certainly shot up. Similar thing has been tried successfully in CMV, CMV becoming positive, donor search has been done, adoptive T cell transfer is done, and the CMV titers gone down. So this is an exciting new way to treat viral infections. So this is feasible, this is safe, and this can restore immunity. And there are various banks which are already available to use it. That's basically what I was saying. If you look at graft manipulation, which is the other bit, but this is all basically where you have a graft and we want to be sure that we use it carefully.
Time is up. So.
Time's up? Can I just take 2 slides? Just 2 slides.
Okay.
I kind of said that I'll come back to the skid transplant to talk about whether conditioning should be done or shouldn't be done. And this is just because with if we have a T neg, B neg, then these are the patients basically. If you have a skid, then these patients possibly are the ones for whom you can actually do a transplant without conditioning. But what we now know that for most patients, it's actually, even the skids, it's possibly better to condition them before a transplant because they have better thymopoiesis after that. And this is another change that has happened in the last few years. If the same question was asked 2 years ago, we would have said that you don't need to condition skids. Now we're saying, yes, probably you do. Thank you.
Thank you. We could take a couple of questions.
Pertaining to the last statement, can I know the explanation for the same thymopoiesis better with the conditioning?
So,
because when in this setting, in adult setting, it is well established, but in this particular setting. So
this is basically something that has happened in the last couple of years because a lot of data has been shown that traditionally, especially in skids, even we were kind of taught that you do not need to really condition these patients because they don't have functioning T cells. Whatever cells you put in, it will engraft. However, some of the genetic skids where you have a T neg, B neg skids, if you use a transplant without using conditioning, the T cells engraft, but they have a continuing problem with immunoglobulin, with low immunoglobulins. And more than 45% of all these patients go on to lifelong immunoglobulin replacement therapy. So their major problem is solved, but they still have a need for frequent hospital visits to keep up with immunoglobulin replacement. So even for these patients, what now the dictum is that use, even if it's a little bit of conditioning, might be something mild like a little bit of fludarabine and thiosulfan, and you have a better engraftment which is more long lasting, and you would not have more problems after that. Yes. Hi.
Any more questions?
Hi. Thank you, Dr. Shantanu. So my thing is, since you have moved from the era of Buci to fludarabine-based conditioning for almost all immune deficiencies, are there some deficiencies that you're still using Buci, like maybe CD40 or something, which has still problems with engraftment?
Possibly. So I think what we have realized is that possible complications from using more traditional conditioning, as you said, with Buci are quite a lot. So most of us have moved away from it, but yep, some of them we do.
So there are still some genetic deficiencies where you would use Buci.
Correct.
So, any more questions? So what is your take on transplantation for X-linked A-gamma globulinemia?
If those patients can be managed with proper immunoglobulin replacement, and if their quality of life is good, then you got to weigh up whether it's worthwhile taking them through a transplant. There is some data to say that even with that, there might be some patients who might benefit from it. And at the end of the day, it will be a clinical decision, and might be also to speak to the parents and see what they feel about it.
Thank you. Thank you very much. So on behalf of my co-chairperson, Dr. Uni, and the organizers, we would like to thank all the speakers, Dr. Mukesh, Dr. Yunus, and Dr. Shantanu, who've probably given us a session that would result in permanent change in practice and improved survival and outcomes for children with primary immune deficiency. We have been honored to chair this session. Thank you.
Thank you, Chairperson and the speaker for the wonderful session. Now we shall break for lunch symposia conducted by Shire. Lunch will be served in this hall. The next session will begin sharply at 1:15 p.m. It will be selected oral presentation. The presenters are requested to be in their respective halls at least 10 minutes prior to the session. We also have the Meet the Professor session between 12:15 to 1:15 p.m. Candidates registered for Meet the Professor session can collect their packed lunch and assemble in the lobby. For the speakers for the post-lunch session are requested to upload their presentation in the preview room located in the